Good evening, dear friends. A warm welcome to this Rising Stars of Retina program organized by the Cochin Ophthalmic Club. I am Dr. Sai Kumar. I am president of the Cochin Ophthalmic Club, and we are indeed glad to have a big panel of retina specialists and retina fellows in this audience. We have, almost every week we are having some sort of a webinar or the other. We decided on a very unique way of presenting cases. Dr. Gopal, our secretary, who has made this entire program, will brief you about how we plan to go about it. And so it's my very pleasant duty to welcome all of you to this great meeting. I hope everyone enjoys this meeting. We will have the president of the Kerala Society, Dr. Meena, who will join us shortly to officially inaugurate this program. And I hand over the proceedings to Dr. Gopal now. He will basically tell us about the format of this program and also welcome the moderators and all the panelists to this audience. Dr. Gopal, please.
Thank you very much, sir. I hope I'm audible.
Yes, you are.
Yeah. So this program is basically meant to bring out our senior fellows in retina and those who are into retina, just coming into retina. They are the rising stars, and they are all getting mentored by consultants in retina in the nation, right from Dr. Anand Rajendran from Arvind Chennai, Reema Bensal from PGI Chandigarh, Rohan Chawla from RP Center, Oi from Tel Aviv University. Then we have Alok Sen from Chitrakoot, and our own Manoj from Chaitanya, and then Dr. Rehna Rashid from our Amrita, Divya Balakrishnan from Giridhar Eye Institution, and Ramya from Little Flower. These are the 9 mentors who will be mentoring the young and rising stars of retina. We have in our panel Dr. Giridhar, who is the senior most retinal surgeon in Cochin, and as you know, he's a all India figure. And then we have Dr. Dinesh Talwar, my teacher and my mentor, and Dr. Hemant Murthy. Dr. Dinesh Talwar was professor at RP Center, and now he's with Center for Sight. And Dr. Hemant Murthy is in the Retina Institute of Karnataka. We have also Dr. Meena Chakrabarti, who is a senior retinal surgeon in the country. She is our Kerala Society president. And we have Dr. Thomas Cherian and Dr. Mahesh Gopalakrishnan, who are part and parcel of the Cochin Ophthalmic Club. And they are 2 exciting retinal surgeons that I have with me. So the whole conference, the whole meeting is on a 4-minute presentation, a 4-minute discussion by a mentor, and then they will pose certain questions to the panel, which will initiate the discussion, and then we will have a small panel discussion for about 4 minutes. So I think each case will take about 12 to 15 minutes, and then we will go to the next case. And in between, we have a small diabetic macular edema. We require to actually look at some case scenarios and how each of us are going to treat those conditions. I also thank Allergan for kindly helping us conduct this particular program. Let us go to the first case. Dr. Meena has come. Madam has come.
No, I don't think she has come. I think we can go on with the cases.
Okay, we can go on with the cases. Aruna is going to present our first case from Arvind Eye Hospital, Chennai. You can share your case. And Anand will be discussing it. You can unmute, Aruna.
Yes, sir. Am I audible, sir?
Yes.
Yes, you are, Aruna.
Yes, sir. A very good evening. Today I'll be presenting a very interesting case of uveal effusion, and the session will be moderated by my mentor, Dr. Anand, sir. A 56-year-old male presented to us.
Full screen, please. Yeah.
Yes. A 56-year-old male presented to us with complaints of left eye painless progressive diminution of vision over the past 3 months. He was a known case of diabetes, hypertension, and cardiac under treatment, not a smoker, no history of steroid use, and no similar illness in the past. On examination, right eye vision was 6/6, IOP and anterior segment examination was normal. Left eye vision was 6/12, IOP and anterior segment examination was normal. Fundus examination of right eye revealed choroidal folds and drusen, and left eye, apart from choroidal folds and drusen, there was an obvious serous detachment at the macula. OCT clearly showing intraretinal edema, subretinal fluid at macula, and pachychoroid features. The second is a line scan at the level of choroidal folds. Right eye also had pachychoroid features in OCT. So left eye FFA, though there was not a classic CSR leak, ICG clearly revealed hyperpermeable pachy vessels, and there was staining of drusen and choroidal folds are seen. We arrived at a diagnosis of both eye pachychoroid with left eye CSCR, and left eye ICG guided photodynamic therapy was done. And he was advised a follow-up of 1 month. At 1 month follow-up, he had regained a vision of 6/6 and anterior segment examination was normal. And here we can clearly see his response to PDT with complete resolution of the subretinal fluid. Unfortunately, at 3 months, the patient presented back with us with defective vision and increasing metamorphopsia. Anterior segment examination was normal. On left eye examination, surprisingly, this time he had developed a significant optic disc edema along with recurrence of subretinal fluid and choroidal folds. Here we can see that there is peripapillary subretinal fluid, optic disc edema, intraretinal sciatic edema, subfoveal detachment, and persisting pachychoroid features. And this time, when we repeated FFA, there was a development of florid disc leak and hypocynescence at the PDT site secondary to choriocapillaries atrophy. On comparison of the FFA, there was a development of florid disc edema, and hypercynescence has become hypo secondary to PDT. And B scan showing diffuse choroidal thickening. And both the axial lengths were around 21 millimeters. All blood investigations were within normal limits, ruling out inflammatory pathology. Our diagnosis was left eye uveal effusion syndrome. And based on evidences from multiple reports, we started the patient on steroids, and we chose dexamethasone over triamcinolone, considering his systemic status. Post-injection day 1, patient was symptomatically better, but within a week span, his vision dropped down to 6/36 from 6/9. AC was shallow this time. On examination, we could see that the disc edema was decreasing following the steroids, but there was a paradoxical increase in the subretinal fluid. Here we can see clearly that the optic disc edema had relieved following the steroids, but there was an increasing subretinal fluid at the macula. And B scan showing increased choroidal thickening when compared to the previous visit. And the patient underwent both eye prophylactic YAG-PA for his both eye PACA status, and we repeated injection dexamethasone. 5 months follow-up, his vision was stable at 6/36. And on fundus examination, disc edema had relieved, his pallor had set in, diffuse leopard spots were seen, and this time the patient had worsened, developing exudative RD and peripheral CDs. B scan clearly showing exudative RD. And in OCT, we could see that there was increased bumpiness of the choroid with the hyperreflective dots both in the retina and the choroid, along with pre-existing intraretinal edema and subfoveal detachment. And at this juncture, the patient was advised to undergo a left eye subscleral sclerectomy. The patient was not keen on surgery and lost to follow-up for 3 months. And when he came back after 3 months, his vision had further dropped down to 6/60 from 6/36, and he has developed a significant cataract of nuclear sclerosis grade 3. Surprisingly, on fundus examination, we could see that there was a spontaneous resolution of exudative RD and CD, and we advised a cataract surgery for the patient. And FFA ICG showing leopard spot retinopathy. Following cataract surgery, his vision improved to 6/12 from 6/60, and there was a complete spontaneous resolution of the RD and CD. Left eye clearly showing complete resolution with pachy features still present. And summarizing our case, a patient who initially presented as a CSCR with pachychoroid features, who responded very well to PDT with complete resolution. Later, there was a recurrence of subfoveal detachment with optic disc edema, The optic disc edema resolved following IVTA, but the patient worsened and progressed to develop a exudative RD and CD. When he was advised surgery, he didn't turn up. But when he turned up, there was a surprisingly spontaneous resolution of the exudative RD and CD. And we have a follow-up of around 1 year till now with no recurrences. So unique features of our case is CSER morphing with uveal effusion syndrome, features of pachychoroid and uveal effusion syndrome, and spontaneous resolution of uveal effusion syndrome. And our questions to the panel will be, what could be the trigger for the development of uveal effusion in this case when the CSER had resolved well following PDT, and what led to the spontaneous resolution of uveal effusion with such a massive exudative RD? I thank Anand sir for this opportunity and Cochin Ophthalmic Club for coming up with this great idea. Thank you.
So thank you, Aruna, for beautifully portraying that case. So Gopal, should I just add a few comments before we move on to the panel?
You have some presentation?
I don't know, we have a few supportive slides because this is a pretty long presentation. So we've got a few supportive slides for discussion.
Yeah,
but,
please do that.
I'll just, so Aruna has that. If you want, she can continue with that. But before she does, I'll just like to summarize this, case. So this basically was a pachychoroid presenting as a case, very straightforward case of CSER, which responded well to PDT. Then soon after that, very insidiously, the uveal effusion started developing. And then as we went by, there have been reports of uveal effusion in milder forms responding to steroids, corticosteroids, as well as topical, as well as oral corticosteroids. But we did not really go ahead with oral corticosteroids for two reasons. One, patient obviously presented with the CSER. And second, a small challenge was given and he had gastritis and he couldn't take it. So that was ruled out. So therefore, we gave him a challenge of intravitreal, intramuscular dexamethasone. The driving reason for that was the disc edema. And as you saw, the disc edema actually responded, but then the serous fluid started developing in the macula, to the point that in time, unfortunately, developed a fairly massive exudative detachment, which you can see coming up on the ultrasound. In fact, the exudative detachment almost came up under the lens. And that, according to Uyama's article, seminal article, is a clear indication for subscleral sclerectomy, which I'd advise the patient. Unfortunately, patient never turned up. And then when he did, to our surprise, it resolved completely. Of course, there was an increase in the cataract density, and cataract surgery was done. And at this time, when he presented the detachment, he also came in with the shallowing of the angle. So that's something which we know. It was almost like a PACG. And PI was done. Finally, after cataract surgery, you can see that very clearly now that there was a spontaneous resolution. So a lot of unique features here. And as the questions have been put out, what could possibly, what we did not usually, you see this developing over a long period of time, but this was all, the entire spectrum came together. So what we'd like to suggest, and we're trying to publish this, is that perhaps uveal effusion syndrome in a case where you see pachychoroid with CSER with choroidal folds, and we'd like to drive home that point, with choroidal folds, perhaps you should think that this kind of a situation can happen, and perhaps uveal effusion syndrome could be at the extreme end of a pachychoroid spectrum. That's what we'd like to drive home here. A few questions for the panel, and we'd like, Gopal, if you want, we can take those questions first, or we can go ahead and just show you some of the theory related slides if you want to.
I think we can.
I think we can have some discussion.
Yeah, I think that would be better right now.
Yeah.
We can bring up the theory slides as we, progress with the discussion.
Can we stop sharing then?
Yeah. Can you stop sharing, Aruna?
Yes, sir.
Yeah, Anand.
Now,
Before,
yes.
Can I make?
can I make some comments in this case, basically?
Yes.
Yeah, Dr. Giridhar, you can start off.
I mean, just for the discussion's sake, interesting case, a very interesting case, a very unusual case. I mean, initially from the OCT that was shown and the picture, I mean, unfortunately, we don't have a wide-angle retinal photograph initially just to see what exactly was the condition of the peripheral retina at the time of the initial presentation. We also do not have an ultrasound in the initial presentation. So these are, two important areas where probably we do not have any information as far as the initial presentation is concerned. But then considering that this was a case of central serous retinopathy initially, and later presented in a different way, especially probably the disc edema is the one that is probably the most important feature. And then after that, so this patient has got a pachychoroid element. And in a pachychoroid central serous retinopathy situation, the patient had a suspicious effusion syndrome for which steroids were given. Steroids can aggravate pachychoroid disease. And steroids probably is the cause for the significant exudative detachment that occurred subsequently. And probably that's the reason why once the steroids were stopped, the exudative detachment resolved. So there is a lot of things that can be explained on the basis of the course of the disease. And therefore, if you cannot really say that based on this one case, that uveal effusion syndrome is one end of the spectrum of a pachychoroid disease. So that is my main argument.
Okay, sir. So you mean to say that steroids are the culprits which drove the exudative retinal detachment?
Possible.
Yeah.
To a certain extent.
Anand, you wanted to say something about it?
Yeah, just this thing. It was not a prolonged course of steroids.
No, whatever it is, it's a high dose of steroids. See, when you give dexamethasone, dexamethasone is something like a bolus steroid which has got an immediate effect. So it's not like giving an oral steroid which has got a prolonged effect. But then this is a bolus steroid, so which has got an immediate effect. Therefore, suddenly you're pumping steroid into a system where probably there is a tendency for a patient to react in such a way, considering what has happened earlier. It is possible that the exudative detachment, and that way we can explain how this condition completely resolves spontaneously over a period of time without any form of intervention.
Okay, Dr. Hemant wanted to speak.
Yes, can I? Yeah.
Okay.
Anand, I just want to ask you. Yeah, Anand. One question is, we know that if there is peripapillary pachychoroid, it can induce ischemic optic neuropathy. So the feature of an ischemic optic neuropathy could be one of the reasons why the disc edema developed and the patient became symptomatically better because of the steroid. But the steroid worsened the exudative RD, and that's the whole thing you can explain on that aspect. Peripapillary pachychoroid is known to produce ischemic optic neuropathy. That's why.
But I just my thing to this is that we gave the steroids after the patient developed the uveal effusion, not before.
Okay.
So it was a response to the uveal effusion and it was only a intravitreal dexamethasone and IM, which is a short challenge because the disc was getting choked. It was to decongest the disc that we gave. Not in response to the.
Anand.
Yeah.
One thing I would like to make it clear in our discussion, both me and Hemant are not questioning the administration of steroid. We are not questioning the administration of steroid. So once there is a disc edema like that, definitely we have to give steroid. But what we are telling is some of the sequelae that have occurred is probably related to a certain extent because of the steroids, and therefore it cannot be totally attributed as a case of a uveal effusion syndrome with extensive massive exudative retinal detachment. Because, we have seen so many cases of significant exudative retinal detachment in steroid-induced central serous chorioretinopathy. So basically, it is known to occur. Therefore, and since this was, this was given as a bolus, there is a possibility. That is all. We are not questioning the role of the steroid. Steroid had to be given at that time.
Anand, I would like you to just do a fields and check whether the patient had ischemic optic neuropathy.
Okay, right now, of course, it's passé because he's.
But you'll still have altitudinal defect in these patients.
No, but there was no pallor in the disc, sir. There was no pallor in the disc.
Very minimal pallor, but
segmental pallor was not there.
So that can be secondary to the fact that the fluid was there and choking. So that could be secondary. We're not saying that is not there. What we are saying is that when you see this case, it was not a straightforward case of a pachychoroid CSCR. The point that I'm trying to drive home is that there were choroidal clefts at the start. There were choroidal lines of hypofluorescence, which you do not see in a typical case of pachychoroid CSCR. So this case, this was a short eye, 21 millimeters. 21 millimeters in both eyes. There was the stuffed choroid right there, and it is those. So what we're trying to say is, when you see a pachychoroid with a leak happening, and this was not a classic leak, this was just a very diffuse leak, and there were choroidal folds. What that choroidal folds is that in a short eye, you have a thick amount of choroid being stuffed in, and that's why it's getting crenated. So when you see that, it is possible that this is a different situation from your regular pachychoroid CSCR with a typical leak, ink blot or smokestack. So when you see that, it's important to understand that this kind of situation could happen. What was interesting in this case is it happened within a short period of time, and only very small, episodes, 1 or 2 episodes of these steroid challenges were given.
Okay, Anand, Rohan wants to make a point.
Yeah, please.
Can you just make Rohan?
Yeah.
You can unmute.
Yeah, I think what Dr. Anand is saying, that this case becomes a little different because the eye is small and there were already pre-existing choroidal folds. So as I written in the chat, that we also have published a similar case with a multifocal CSR exudative detachment, and that also resolved with a partial sclerectomy. So I think that is an important thing, where when things start worsening in such a manner, that could have, that as they had also suggested, probably is the line of management.
I think one of the important take-home messages is that I think Rohan, there are a lot of patients. In fact, today also we had a lady, about middle-aged lady with a central serous chorioretinopathy with about 7 months history. The fluorescein angiography actually doesn't show anything at all. So possibly, some of these cases, it may be worthwhile to just see whether the biometry and the diameter of the eye, to see whether these are smaller eyes and whether there is any predisposing condition like that.
Absolutely, sir. Absolutely. That's the whole point, because this patient came in not just with serious massive inferior choroidals also. So it is a very florid picture compared to what the patient presented with. So it is very, dramatic actually.
But then, I mean, the worsening is definitely to a certain extent related to the steroid treatment.
So that's just 1 second, Dr. Dev. 1 second, just sorry. When you see the 2017 paper publication by Carol Shields, they have put out a huge article, it's an IGO, where they've suggested that steroids is the way to go for non-ophthalmic uveal effusion.
Yeah.
And there's a treatment. So this is what we would like to caution also. In my experience, I have not seen steroids doing a great job with uveal effusion, and we really like to actually, caution against that. But the Shields have said that only 5% of their cases needed sclerectomy, whereas our experience has been different.
But it would be like normal sized eyes. But yours is a little smaller eye.
Yeah, there's also some were smaller. Ours was slightly smaller. Nanophthalmos, the magic number is 19 and 18. Yes. So 18 is the nanophthalmos.
So in conclusion, just to conclude, this is a CSR pachychoroid spectrum in which there was a transformation to a more sinister uveal effusion syndrome. And to treat a uveal effusion syndrome right now, steroids is the mainstay of treatment. That is what you would want to conclude and give as a giveaway message.
May I just want to know, are you saying that there's a transformation of the CSR into this?
No.
It's a separate thing that just
morphologically it looked like a CSR to start with.
It's an incidental thing that happens secondarily. It's not related to the CSR, and I wouldn't call the thickened choroid of the uveal effusion as a pachychoroid spectrum, because there is over here there is a different cause. You're talking of restriction of flow. Basically, this is almost a nanophthalmic eye, and basically you have a different pathophysiology. It's a you're dampening the flow. That is why the choroid is thickened. Not that the choroid was in CSCR. There is no prevention for flow to happen.
No. See, what we are saying is this could be when it presented as a CSCR, it was the beginning of a uveal effusion. So in CSCR, there is an increased hydrostatic tension in the choroidal compartment, and this kind of weakened and blew the RP in a very diffuse, mild manner. Presented initially as
so don't say it is CSR. The sensorineural detachment was as a result of
but then it showed classic choroidal hyperpermeability, and it falls within what's paid as averred and said, it is a CSCR with hyperpermeability and you treated it.
All right, Anand. So I think we have a lot more cases with choroidal thickening and pigmentation and mottling and lots of similar cases, but dissimilar diagnosis. Let's move on, sir. Okay, so next case we will have Nitin Kumar from PGI. Dr. Giridhar, your video is off actually. Can you please on that?
I'm sorry. There's something wrong. I'm sorry. There's something wrong. Yeah.
Okay.
I'll try and set it right.
Okay. Nitin is from PGI and Rima Bensal is his mentor. A challenging case of retinopathy in a patient on oral methotrexate. Over to you, Nitin.
Good evening, everyone. So my case is a challenging case of retinopathy in a patient on oral methotrexate. So this is the brief history of the patient. A 49-year-old female presented to us with decreased vision both eyes since 2 years. The decrease in vision was gradual in onset, painless and progressive in nature. The patient was a case of rheumatoid arthritis and was on treatment for last 2 years. She was being managed with oral methotrexate 20 milligram daily, and there was no other systemic illness. There was no history of any night blindness, no history of similar complaints in family members. She did not have any history of weight loss, swelling anywhere else in the body, no history of any loss of appetite or any generalized weakness. So at presentation, when she presented to us, the visual acuity, best corrected visual acuity in both eyes was 6/60 and intraocular pressures were 12 millimeter of mercury in both the eyes. AC was quiet in both the eyes. The right eye, she had undergone right cataract surgery elsewhere, and left eye, she had a mild PSC. So when we come at the fundus examination, the disc was slightly pale. There was presence of arteriolar attenuation, and there was presence of these widespread RPE atrophy all over the fundus with mild sparing of the fovea in both the eyes, which can be seen clearly in this photograph centered at the macula. So again, we can see this disc pallor, arteriolar attenuation, presence of this RPE atrophy, which was more in the nasal quadrants in both the eyes, and the dull foveal reflex. So this is the fundus autofluorescence of both the eyes. We can see that there are widespread areas of hypoautofluorescence all over the fundus with relative sparing of the macula, and similar picture is seen in the left eye. And we can see that in the left eye, the more changes were in the nasal periphery. So this is on the Heidelberg. Again, widespread areas of this RPE atrophy causing the hypoautofluorescence. This is the right eye, and this is the nasal area. This is the left eye. Again, the presence of these hypoautofluorescence and relative sparing of the macula. So we went ahead with the optical coherence tomogram of both the eyes. As we can see, right, there is foveal atrophy with atrophy of almost all the layers at the foveal center, and a few cystic spaces could be seen nasally. And at the level of the temporal retina also, there was presence of this atrophy corresponding to the RPE atrophy temporally. In the left eye also, again, we can see there was presence of atrophy, but not as much as in the right eye, with this loss of the outer retinal layers and loss of the photoreceptors with few cystic changes. We went ahead with visual fields 24-2 for this patient, and we could see that there was gross constriction of the visual fields in both the eyes. Further, a full field electroretinogram was carried out for this patient, which showed reduced amplitudes of A and B waves, the photopic as well as scotopic responses in both the eyes. So keeping in mind the history and examination of this patient presenting with a optic disc pallor, arterial attenuation, widespread RPE changes, constricted fields, and no other significant history, we kept the diagnosis of autoimmune retinopathy, non-paraneoplastic. The patient had underwent a complete examination by the physician which was treating her, and they had not found any other etiology for this patient. Also, other probability which we kept in our patient was a whether it was an oral methotrexate induced retinopathy, as the patient was taking methotrexate for almost 2 years. Retinal dystrophies was very down the line for the diagnosis, as it is very not for this age group. So points in favor for NPAIR was that there was presence of concomitant concomitant autoimmune disease like rheumatoid arthritis. The typical ERG changes which are seen were present in our patient, and this speckled autofluorescence which has been explained in the literature. Also, one of the point was that it has been reported in literature that non-paraneoplastic autoimmune retinopathy responds poorly to the immunosuppression, as was in the case of our patient. However, the patient was quite sure that 1 year back she was almost having 6/9 vision. She had got examination done from outside before starting the methotrexate, and there was no retinal changes, and she was having a visual acuity of 6/9. So majority of these autoimmune retinopathy patients may not have any ocular findings at presentation, but in the late stages they can have these widespread RPE changes. However, the autofluorescence changes are mostly in the form of a hyperautofluorescence ring in the parafoveal region and hypoautofluorescence around the optic nerve. Also, on OCT, there is generally involvement of outer retinal layers, that is the ellipsoid zone and outer nuclear layer. As far as oral methotrexate toxicity is concerned, retinal degeneration occurs in these patients. There are widespread, the ERG changes are almost same as seen in our patient. And there was specific history by this patient that she had this worsening of vision only after the initiation of methotrexate. However, we don't have any documented pre-treatment fundus photography and ERG recordings for this patient. Retinal dystrophies, generally it's very rare to have starting at this older age. So as NPAIR is a group of inflammation mediated retinal disorders, which is characterized by reduction in vision, dysfunction of photoreceptors and defects in visual fields. However, there is no cancerous lesion detection in cases of non-paraneoplastic AIR. In the early phases, there can be little or no pigment epitheliopathy, and in this major review, they have written that generally there is a sudden progressive visual loss. But however, in our patient, there was a gradual decrease in vision. There is no clear-cut diagnosis for AIR, and there is all need for further testing also, which was refused by our patient. She does not underwent any antibody testing for anti-retinal antigens. Also, as I have highlighted previously, the hypoautofluorescent changes are mostly around the disc, and hyperautofluorescent changes occur at macula, which was not seen in our case. Also, there was complete atrophy as seen in the right eye, but there is relative sparing of outer nuclear layer and ellipsoid zone in cases of AIR. However, there can be a mixed pattern in AIR in OCT as well as hypoautofluorescence. So our patient reported loss of vision while receiving methotrexate. However, it is thought to be protective in autoimmune retinopathy. Patient also had received previously oral steroids, which is also recommended for the treatment of AIR. However, the retinopathy did not improve. This is one of the images which have been taken from the major review on autoimmune retinopathy. So we can see there is mostly changes in the parafoveal area, these hyperautofluorescent changes. As far as oral toxicity due to oral methotrexate is concerned, it is generally limited to the anterior segment in the form of dry eyes, photophobia, conjunctivitis, blepharitis, and decreased tear production. Posterior segment toxicity is extremely rare. These are in which they have given chemotherapy for treatment of CNS lymphoma and intraocular lymphoma, and they had reported maculopathy in these patients. One of these is by Miller et al., who reported visual loss and maculopathy in 11 patients who had received intraarterial methotrexate for CNS lymphomas. This is another case report, which this was a young child who had developed severe visual loss following methotrexate therapy for psoriatic arthritis. They have not specified the route of administration, but they had noted that after stopping methotrexate, there was reversal of the ERG changes, but not much of a visual gain. So widespread RPE damage can occur in cases of methotrexate toxicity, oral methotrexate toxicity, because RP cells are highly active metabolically and divide rapidly. They are more vulnerable to and prone to drug toxicities, as is seen in case of hydroxychloroquine and ethambutol. So methotrexate toxicity could have been a possible diagnosis in our case. So our questions to the esteemed panel is that if it was NPR, how should we treat this case? Continue methotrexate or give any other metabolite or IVIGs? And if it is methotrexate toxicity, should methotrexate be withdrawn, as it was seen in the case report in which the child's ERG improved after stopping the methotrexate? Thank you.
Thank you very much, Nitin. You can stop sharing. I think the slides are over, or Dr. Rima has further slides.
You can stay on the slides.
Okay.
On the literature slides.
Okay, Rima.
Show the child with methotrexate, where they withdrew methotrexate. So yeah, meanwhile, so the challenge in this case is that we still feel it was paraneoplastic autoimmune retinopathy. But then certain things that can we really ignore oral methotrexate toxicity, because all the literature of oral methotrexate toxicity talks about, first of all, it's very rare to involve the posterior segment. Most of the toxicities, whether it's oral or intravitreal, are limited to the anterior segment. And whatever is reported in posterior segment is the changes, are the changes in the RPE in the macular region. And thirdly, even if the changes are there in the macula, these have not been documented to have very significant visual loss. So now in our case, the changes were quite in the periphery, more consistent with autoimmune retinopathy. There was significant visual loss. This did not, of course, corroborate with retinitis pigmentosa, which is again a differential when you think of autoimmune retinopathy, because there was no night blindness, there were no bony spicules. So the challenge is how to proceed with this case. Do we stop methotrexate, we consider IVIG, or we continue with methotrexate, shift to MMF, cyclosporin, or other antimetabolites? So this is the question to the panel.
Yeah, a very nice case, Rima. Just my small amount of comments that I could think of. I think the only other toxicity that is known is optic neuropathy, which I think is because of the folate deficiency that occurs as a metabolic consequence. I think that's the only thing that is mostly reported in this. Now, as you rightly said, it looks like autoimmune retinopathy because a lot of features are together, but some changes in the macula are not going hand in hand, which is why the confusion has come, whether methotrexate toxicity is a feature, which I feel could both of them be coexistent in the same patient is the only thing, because some features are.
Stop here, Nitin. Now, if you look at this.
So this actually, if you're in your OCT also, you can see that there is sparing of the outer nuclear layer, but there is loss in the center, which is not generally a feature of.
Yeah, they have described a flying saucer sign in that, it's sparing, it's spared at the fovea, and you have involvement in the parafoveal region.
Right, correct. So this is just that there is all other signs, but you have got the foveal involvement in this. That's the reason why you're. So is this the foveal involvement is due to methotrexate toxicity, and the rest are features of autoimmune retinopathy? Could that be coexistent? Is only the question is.
No, I mean, as a clinician, I don't think I'm a great expert to comment on this case, but as a clinician, what I would say is that if there is any drug which can be given other than methotrexate, I personally feel that in such a situation, there is no harm in changing the drug if there is an alternative. Because we have a situation where a patient, this looks more like an autoimmune retinopathy. I don't think that this is basically a case of a methotrexate toxicity, because I went into the literature for methotrexate toxicity. There's hardly anything any published literature showing such extensive damage to the retina as a result of methotrexate. And if you see the few cases that you have presented, one is a combined chemotherapy where other drugs also were given along with methotrexate. So we really do not know whether it is because of methotrexate. And the other one was intravitreal methotrexate, which was given. So basically, I mean, long-term systemic use of oral methotrexate as a single drug, I don't think there is any published literature on such a severe retinopathy. So considering that there is always a possibility that long-term methotrexate can cause some degree of damage, and since already there is so much of pre-existing damage in this particular patient, probably as a clinician, I may suggest that if there is an alternative drug, probably that's worthwhile using it at this point.
That's what we actually referred the patient back to the treating physician, asking for an alternative, since we were also not very sure. And, you know, making a diagnosis, confirmatory diagnosis of autoimmune retinopathy is a big challenge here. So I think the patient did not get back to us. This was, we had seen a few months before the COVID thing. So
why is there an asymmetric involvement of the two eyes? The left eye, though the vision is bad in both, but the OCT is almost normal foveal thickness in the left eye. But there is a little bit of involvement of the ISOS junction. So, I mean, it's a little strange that why should, that means though if it's happened together, I mean, if it's drug related, it's happened together, you expect both to go the same way. That's not happening here. And the vision loss, is it possible there may be something else? Maybe this is optic nerve rather than the retina. That retina is there, but the retina is asymmetric. It's not the same in both the eyes. So if it was drug related, it should be identical or very close to each other.
Or do we take it as an already compromised eye with autoimmune retinopathy getting worsened with oral methotrexate?
Possible.
Rima, I just wanted to ask you that the methotrexate that we were taking was about 10 to 15 milligrams.
20 milligrams.
20 milligrams. But in chemotherapeutic dosage for cancer, I think we are using much higher dosage. And all the reports which you have seen, are they using very high dosage? Is it dose dependent or duration dependent toxicity?
No,
or is it idiosyncrasy?
Because here the dose that we are using is a very normal dose. It's not the chemotherapeutic dose.
Yeah, it's a very lower dose as compared to that.
It's an immunosuppressive dose.
Yeah.
And secondly, the whatever few reports we have, either it's because of following intra-arterial, which is a direct this thing, you cannot compare it with the oral dose. And the second child where they withdrew, they did not mention the route of administration, and probably they they withdrew at an early stage, or we really don't know. So here I think the stage is quite irreversible. It's just that we have an option of offering to the patient that, and physician, counseling the physician that it's better we switch to another agent, because let's at least prevent the further harm. We can't undo what is done.
Okay, so Rohan is asking whether you can suggest from where you can get a complete panel of anti-retinal antibodies in India.
I'm not aware of it.
Yeah,
okay. Anybody is aware?
I mean, I don't think anyone has been doing it in India. I'm not sure about, because we have also...
I did try to find it out, and there are few single case reports by Dr. Sudha Ganesh's group. Earlier they had published almost a decade ago where they didn't do the antibodies, and one they had published a few years ago where they did do the antibodies, but that was with the I think with help from Dr. Rao, Keck School of Medicine.
Okay.
So I don't think anybody has acknowledged the antibodies being done in India. I would like to know if somebody is aware of, and even if they are available, it's quite expensive, I believe.
Any comments from Dr. Avi from Tel Aviv University? Do you have any experience with anti-retinal antibodies?
Actually, in Israel, I don't think we have this lab test, but we send these cases to United States to have them tested.
Okay.
So that's what the SN group also did.
Okay. So I think we can, thank you very much, Rima. I think if the discussion is all, let's move to the next case.
Thank you. Thank you, Gopal.
Yeah.
Thank you.
Dr. Nasik, are you ready? Dr. Nasik will present a curious case of pigmentary retinopathy again. So I'm telling you, I'm warning you, there are lots of pigments, there are lots of choroidal thickenings, similar looking cases, different diagnoses coming in. Okay, and Dr. Rohan Chawla from RP Center will be mentoring him. Yeah, over to you, Nasik.
So is my screen visible, sir?
Not yet.
Just a second, sir. So is my screen visible?
Yeah, it's coming in.
Yes, sir.
You've started screen sharing, but it is not visible yet.
Oh. Yes, sir. Is it visible now, sir?
No.
I can see it.
Yeah, even I can.
It is visible.
It is visible, sir?
Yes, it is visible here.
Okay.
Thank you, sir. Good evening to one and all. I would like to thank Dr. Gopal sir and Rohan sir for giving me this opportunity. So I'll be presenting a case of pigmentary retinopathy. So there was a 65-year-old lady who had presented to our center with gradual progressive diminution of vision for the last 6 months. She had severe contraction of her visual fields. She was a diabetic and hypertensive. There was no history of night blindness, no family history or trauma. She was diagnosed as retinitis pigmentosa in multiple centers elsewhere, and the visual fields performed elsewhere also showed generalized constriction of the fields. On examination, her best corrected visual acuity was 6/60 in the right eye and 3/60 in the left eye. Her anti-segment examination was normal. She developed NS2 cataract in both eyes. On direct fundus examination, we could see that the media was clear. There was arterial attenuation with mild disc pallor and pigmentary changes in the fovea. The left eye also showed areas of pigmentary mottling as RP atrophy, where supranasal to the in the supranasal retina. So this was the RP atrophy areas. On autofluorescence, we could see diffuse hypoautofluorescence beyond the posterior pole, and the left eye also showed hypoautofluorescent areas which is corresponding to the RP atrophy. FA showed leopard spot appearance, which was corresponding to the RP mottling, and window defects at the area of RP atrophy. Well, now the OCT shows the OCT. There was no there was no vitreous cells. There was no CME. Here you can see small subretinal and sub-RP deposits. In the left eye, you could see a sub-RP deposit over here, and the right eye, you could see subretinal deposits, hyper-intense subretinal deposits in the deep retinal layers. And so with all this, going to a differential diagnosis, our first DD was cancer or melanoma-associated retinopathy, considering our age, the arterial attenuation, and the diffuse RP atrophy. The second was vitreoretinal lymphoma, again considering our age and the subretinal deposits, and autoimmune retinopathy, which also again goes with the cancer, the CAR and the MAR. B dump just because the FA showed a pigment mottling, diffuse leopard spot appearance, and drug-induced retinopathy, which could be due to RP changes following thyroidazine or chlorpromazine. So on further investigating, we are advised an MRI brain and a PET scan to rule out carcinoma or lymphoma. However, the PET scan and the MRI showed hypodensities, which was due to some age-related ischemic lesions. However, the distal large bowel loops showed increased uptake. So a colonoscopic biopsy was planned, and it showed a non-specific inflammatory lesion. We started the patient on oral prednisolone 60 mg, and the vision improved 6/12 both eyes. The dose was tapered every week, but at 10 mg, the vision started dropping again to 6/24. Now the dose was increased back to 60 mg, but the vision did not improve over the next 2 weeks. In between, the patient could not review with us due to COVID lockdown. So the patient came after 3 months, and that time on doing an ultra wide field, just a clinical photograph, what we could see is that there was a similar picture. There was arterial attenuation, but the pigmentary lesions had increased in the periphery. On doing an OCT, we found that earlier there were just subretinal deposits, but now they were distinct sub-RPE deposits, lifting the RPE. However, the Brooks was intact, was normal. There was no CME. So this was quite pathognomic for a vitreoretinal lymphoma. However, we did not have a tissue diagnosis, so we didn't want to start the patient on chemotherapy. Even the left eye showed this sub-RP clump, sub-RP deposit, and there were some subretinal and deep retinal deposits. Well, comparing the OCT at presentation at 3 months, there were new sub-RPE deposits in the right eye. Now again, MRI and whole body PET-CT scan was advised. So this time there was increased uptake on MRI, on the PET-CT in the midbrain and the cerebellum. So, but then this was again suggestive of an inflammatory lesion, query autoimmune encephalitis. And following this, a neurologist opinion was taken, and they had planned a Csf analysis and a neurogen antibody profile. So this neurogen antibody profile was to look for autoantibodies, which is done to load autoimmune and paraneoplastic conditions. It was negative. The Csf analysis showed increased lymphocyte cell count, which could be due to inflammatory etiology. However, infective organisms, and there were no NTB in the CSF. A repeat MRI was done 10 days later when the patient started developing orofacial dyskinesia and was walking difficulty. So again, these hyper intense areas became confluent, but the neurologist again went with the diagnosis of autoimmune encephalitis or an ADEM, which is an acute disseminating encephalomyelitis. Both are inflammatory causes. And the patient was started on IVIG along with oral steroids by the neurologist. But again, they saw no improvement. However, 10 days later, she started developing cerebellar symptoms like cerebellar ataxia and slur speech. This time an MRI was done, and it showed solid areas of enhancement in the posterior fossa and cerebellum. A cerebellar biopsy was planned, looking at the solid enhancing lesion. And this time we could get atypical lymphoid cells in the cerebellar biopsy, which was suggestive of lymphoma, a non-Hodgkin's lymphoma, a diffuse large B cell type. So I just want to say that in this case, we, in spite of the neurologist and the ophthalmologist, both of us having vitreous lymphoma as one of the first DD, we could not start the patient on treatment as we couldn't get a tissue diagnosis. So I would like to hand over to Rohan sir for the discussion part. Thank you.
Thank you, Nasik. Gopal, can I also just quickly show my slides and then maybe we can go to the panel? Nasik, can you stop your screen share, please?
Yeah, please do that.
Okay, so actually what we want to emphasize here is that the clinical picture, even if it is we are very sure that it is lymphoma, many times it becomes very difficult to convince the neurologist that it is lymphoma, because MRIs many times don't show these lesions and we have to be really after them. And these days now that cerebellar biopsy and brain biopsy is probably an option which is there to diagnose it. So what I want to impress on you is that when would you think of a case being of lymphoma? So the first clinical picture now that we have typically seen in many cases is showing these retinal pigment epithelial changes with minimal or absent vitreous haze. And the OCT is very typically showing these sub-RP or subretinal infiltrates. So here you see this pattern where I have marked it is quite typical in an elderly patient. And specifically in the OCT, when you start seeing these deposits under the RP and the Brooks membrane is intact. This, I think, is a very pathognomic feature of vitreoretinal lymphoma, especially in an elderly. The Brooks is intact and the CME is absent. This is from another similar patient we have seen. So you can see that similar changes happening there. But here the OCT shows much more widespread changes under the RP. And also there is intraretinal thickening. Another case we saw, this had a plaque-like subretinal deposit. This also, this case had some vitreous haze. We did a vitreous biopsy. On biopsy, we were able to prove lymphoma. Now, this patient is known case of CNS lymphoma. Here, the OCT just shows intraretinal thickening in this part where the fundus shows a subtle yellowish alteration. So, see, these subtle changes on OCT are important to be looked into in cases, elderly patients, where we can suspect lymphoma. The other one is the more common presentation probably where there's a predominant vitreous haze, which is mostly misdiagnosed as intermediate uveitis, but certain other features make it typical of lymphoma. So this is one such case where the vitreous haze is there. So this one has to understand that OCT of lymphoma, the RP deposits, there can be subretinal deposits. It can sometimes be just an intraretinal infiltration, but important points, it doesn't go into the choroid. It's a primary vitreoretinal lymphoma. So it's not a choroidal involvement here. The Brooks is intact and mostly there is lack of CME. So one can go ahead with a vitreous biopsy when there are vitreous haze or cells, but in this case vitreous was absolutely clear, so I did not want to do that. Chorioretinal biopsy was an option which we missed because of COVID and because the patient's vision was 618. And then finally brain biopsy. But even on chorioretinal biopsy, I think sometimes we may not be able to establish the diagnosis. So regarding treatment, again, there is a lot of controversy. If both CNS involvement is there, then definitely systemic treatment has to be given. But if there is only ocular involvement, then the controversy is that does the systemic therapy actually increase the lifespan? So there are many studies which will tell you that even if you give a combination of ocular and systemic therapy, the 5-year lifespan is still the same. But 3-year lifespan might be better, especially if it is a bilateral case, because this might have multifocal origin. So it doesn't spread from the eye to the brain, but there are multifocal simultaneous origin, and the systemic might be taking care of the subtle micro involvement at the level of the brain. So I think this is from my part, and the questions for the panel are that would they have recommended chorioretinal biopsy, and what would their line of treatment be in cases of isolated vitreoretinal lymphoma? Thank you. Thank you, Gopal, and thank you, Cochin Ophthalmic Society.
So over to the esteemed panel. Yeah, Hemant, sir.
Yeah, one of the things is I would have probably looking at the OCT and your fluorescein and autofluorescence picture, Ron, I would have probably thought of asking for a vitreous biopsy, although the yield sometimes is not as good, but I think that would be a simpler option for the patient to undergo than subjecting the patient for other things. I would have looked at that and then looked at the IL-10, IL-6 ratio and find out whether it's an... I would have thought of that as my first choice in this sequence.
Okay, sir. Just that there was no vitreous haze, so probably in a few cases we have not had any yield. But yes, definitely, like you're saying, it's a less invasive option. Maybe you could have recommended that first to the patient.
So clinically, I think lymphoma was actually the primary suspicion, right?
Actually, from the second OCT, I was 100% sure that it is lymphoma. But the only point was that how to establish it before starting such chemotherapeutic agents. And finally, only brain biopsy was an option, because then finally neurologist also agreed, and he asked me, are you more comfortable with a chorioretinal biopsy? So I said 6/18 vision, loss of risk of loss of vision will have to be explained despite the fields being reduced. So then they discussed and they said that probably cerebellar biopsy nowadays is an easier option for them. So they did it and they found it.
But I think lymphoma always has the last laugh in most of the cases. I think all of us go along this track of trying to find out the diagnosis, and I think.
But in the absence of vitritis, sir, you are telling that you will consider a vitreous biopsy.
That's a less invasive test.
But then even in the absence of vitritis, do you think that you will get any cells?
But you can do flow cytometry and then try to detect it.
Okay, IL-10 and IL-6 levels. Okay. Okay. If there aren't any more questions here, I think we will move to the next case.
Very interesting case.
Yeah.
A lot of information.
You want to make some comments, sir?
No, I don't want to make any comments, but I think Rohan presented the case very well. And I think from a learning point of view, I think he showed very nice. The thing is that I think what we have to emphasize is these things can be very easily missed. Busy outpatient examination, and the importance of color photography and especially wide angle photography cannot be emphasized more, to look for these subtle lesions in the retina, retinal pigment, epithelium, etc., which can easily be missed when we do a clinical examination. And OCT, unfortunately, we look at a very small area of the retina, just the central area, it's a very, very small area. Therefore, I mean, when you see these suspicious lesions and when you push the scan through that particular area, you're able to identify these very classic changes, which can easily be missed when you do a very routine diagnostic OCT examination.
Okay, sir. Thank you.
So, thank you, sir. Thank you very much.
And I think this is what I would like to ask. What would happen if the vision when the patient this patient presented with 660, what if the patient had presented with 612 and these peripheral changes were there and you did not have a swept source OCT?
Even spectral domain will show you some of the RP changes.
No, see, the problem, the reason I'm saying is this is a very common pigmentary change in the older age group.
Yeah.
Now, if you So the message has to be more clearer than this. Either it is that all such patients need a swept source OCT, or you need to find something else that can help you to figure out. See, 660 there's no problem because the vision's gone down so much. You say kuch to ho raha hai. There's something going wrong. 618 or 612, if the patient had presented, it's not the same thing. It could be early macular degeneration. It could be something else going on. Now, how are you going to differentiate in a clear media and you don't have a swept source OCT? What will you do?
Can I make a short comment, Gopal?
Sure, Anand. Sure.
Actually, we had presented a similar case in, I think, one of the rishis, where again, patient presented with exactly what you said, good vision, 612 vision. There, I think the key thing is, apart from OCT, it is also the FFA picture which helps, where you have this pockmarked appearance of this, if you see the picture, that pockmarked appearance, and that also bilaterally. If you see that bilaterally, then it's a very clear indicator. For me, that pockmarked appearance with a central hypofluorescent spot surrounded by a puffy hyperfluorescence around, that is a clear-cut indicator. Also, our regular SD-OCTs will be able to pick out these, what has been described as a triangular subretinal deposits. The sub-RP are little rarer, but are also definitely seen when you especially have those kind of hypopigmented patches which Rohan showed in the mid-periphery. But if you just see those on a regular OCT, you don't even need enhancement. A regular decent SD OCT now will pick out those triangular things, that along with the FFA picture and the ICG picture, which shows that puffy hyperfluorescence, will seal it in favor of
okay.
I think we should just say that in an elderly patient, this is a diffuse bilateral pigmentary retinopathy with mottling. So the 5 DDs that he showed, all of them have to be kept in mind, and one by one we have to rule them out.
Correct. So there is one question from the audience to Dr. Hemant. Sir, is IL-6 and IL-10 quite specific for lymphoma diagnosis?
These tests are just to give an indication, because IL-10 is raised in B-cell lymphoma, so, and IL-6 is for an inflammatory condition. So just a differentiation test. But it is an easier test to do because you can just do a biopsy, which is easier to do and
it's not as
bad as in cerebral biopsy.
Yeah. So now we will move on to our guests from Tel Aviv, Dr. Amir Rosenblatt and Dr. Avi Ohayon. So they will be presenting bugs under silicone oil, subsilicone endophthalmitis. Over to you, Dr. Amir.
Hello, everyone. Just a moment. Hello, everyone, and thank you for inviting us. Thank you for the Cochin Ophthalmic Society and Dr. Gopal for inviting us and giving us this great opportunity to present our case. I'll present this patient. He's a 68-year-old hyperopic patient with a really deep amblyopia in his left eye. He arrived at our emergency room clinic with deterioration in his right eye vision and was diagnosed with macular of retinal detachment. He underwent a fairly standard vitrectomy with a silicone oil tamponade that went smoothly, and came to a follow-up visit 2 weeks afterwards, and the follow-up was again normal. The anterior segment showed no signs of inflammation, and the retina was attached under the silicone oil, and the vision was 6/30. About a week later, he arrives at the emergency room again with severe pain, deterioration in vision, very congestive conjunctiva, and hypopian, and what seemed as a mature cataract that was not there a week earlier. He was diagnosed with endophthalmitis under the silicone oil and was referred very quickly to surgery, which I will present now. So this is the surgery itself, was done by Dr. Ohayon. We can see initially removing the fibrin from the anterior chamber, from the palpion. Then very delicately trying to do the rhexis. Everything was fairly sticky due to the inflammation. And this was the rhexis. Then very slightly hydrodissection, aspirated the cortex, and started with a phaco emulsification, which went fairly smoothly until this happened. What we see is that the nucleus dropped and silicone oil came up. We continued with the surgery. We aspirated all the silicone oil. Looking at the fundus image, we can see the nucleus and some white plaques and hemorrhages. We viscolevitated the nucleus and finished the phacoemulsification and aspirated every segment of the lens. Now the posterior pole was even clearer, and we see really large white plaques and hemorrhages, very characteristic of the endophthalmitis. We finished the surgery with air fluid exchange and a gas tamponade. And eventually we injected vancomycin and Fortim to the vitreous cavity. So at the end of the surgery, the patient remained aphakic. The culture from the silicone oil itself and the vitreous showed staph epidermidis, which was susceptible to antibiotics, and the patient initially improved. Later on, we had a bit complicated clinical course with 2 redetachments that went 2 additional surgeries. So we had the 3rd and 4th surgery. And after the 4th surgery, things seemed to come down. And 6 months later, the silicone oil was removed. Remnants of the lens were washed from the anterior chamber. And the patient, 30 days afterwards, seems surprisingly well, sees 6/15. The vitreous is clear. There's mild ERM, and the retina itself shows macular atrophy, which is fairly expected after the endophthalmitis and 4 vitrectomies. So what we wanted to present is this rare case of endophthalmitis under silicone oil. We know that endophthalmitis after vitrectomy by itself is relatively rare, and much rarer even so under silicone oil. And this is most probably due to the antimicrobial properties of the silicone oil itself. To summarize, we wanted to show this case, 68-year-old patient with recurrent RDs, silicone oil endophthalmitis under the silicone oil, and eventually relatively good visual acuity. Thank you for the presentation, and I will pass the discussion to Dr. Ochayon. Dr. Ochayon?
Amir, can you release? Thank you. I'm going to share the screen. Just a second. The presentation?
Yes, yeah, it's fine.
All right, thank you. So first of all, good evening to all participants and guests, and I thank the organizer for the invitation to discuss this topic. Well, 3 weeks after the first RD surgery, when I left the patient with the silicone oil, I was called to the emergency room to see him, and I really had a diagnostic dilemma because I saw a patient after normal surgery with a white mature intumescent cataract with hypopion. And I was thinking, what can it be? Could it be due to a lens touch that I did in the first surgery? Actually, I was hoping it was that, with a spillover of the cortical material and maybe AC reaction with hypopion to the material, or endophthalmitis after vitrectomy, which is very rare. After studies of Bascom Palmer group in 2004 and the Pan American Collaborative Retina Study group in 2011, which is more rare under silicone oil because of its antimicrobial properties, with groups from India doing this research. So how do we explain the white cataract and luxation during this surgery? Actually, when I extracted the silicone oil was pretty clear. So we assumed that the bacteria surrounded the silicone oil bubble, causing damage to the posterior capsule and zonules, and that's why causing the white cataract and the luxation during the surgery. And of course, the posterior pole was also damaged with the white plaques that you saw during the surgery. And then the challenging thing was deciding what kind of tamponade should I leave in this surgery. well, I was thinking if I would leave silicone oil tamponade, I'm at risk for antibiotic toxicity because of high concentration of the antibiotics under silicone. However, the silicone oil have antimicrobial properties, and if leaving gas tamponade, which that was what I was deciding, that actually allows us to inject optimal antibiotic concentration, but without the antimicrobial properties of silicone oil, and also giving us the possibility to re-inject antibiotics as needed furthermore. And for the follow-up and outcome, you saw that as expected for endophthalmitis patient, he had recurrent RDs, and he underwent membrane peeling due to the PVR that he developed. But surprising outcome, visual acuity of 615, he's very happy, it's only eye. And I guess it's due to the low virulence of staph epidermidis and the antimicrobial properties of silicone oil eventually. So my questions for the panelists, what kind of tamponade would you leave, silicone oil or gas? And what is your antibiotics injection protocol in either tamponade? And even if you had cases of endophthalmitis under silicone, it would be very interesting to hear. Thank you.
Thank you very much, Dr. Hayam. So can you stop sharing?
Yes.
I think I should bring Dr. Dinesh Talwar here, who has done a lot of work in silicone oil, sub-silicone antibiotic concentration and ophthalmitis. Yeah, Mahesh. Yeah.
Oh, same case I had. Same case, actually, similar. After 1 week, he was okay. Then 2 weeks later, suddenly came with mature cataract, all these things. Then what we did was, we checked the video of the first surgery. There was a beautiful lens touch noted in that video. Actually, that is one thing. That case, we didn't get any cultural positivity. Another thing, in this case, there was not much sheathing in the veins during that silicone oil removal, right? Not much inflammation, only few hemorrhages were there. I don't know whether it was actually a infection or no, it is just the same case I had, but it was a lens touch.
Yeah, in our case, we had mainly the white plaques in the posterior pole around the fovea. The fovea was actually quite.
And it was staph. That is why it was, less virulent problem.
From both silicone oil and vitreous fluid.
Yeah.
You have basically you have endophthalmitis, but or at least a severe reaction. But what you have is an intumescent cataract because of a lens touch. And basically, after you had cleaned it, you yourself saw there was no endophthalmitis behind. Most of it was clean. If you have a silicone oil filled eye, and this is the important thing to remember, and if it's, of course, if it's pseudophakic, it becomes easier. If it's a phakic, if it's phakic and becomes cataractous, then that becomes an issue. But if it's not cataractous, and it usually will not be unless there's a lens touch, then the inflammation, the infection gets localized, the anterior segment and behind the oil. The oil itself is impenetrable to any infection. So if you give topical antibiotics, you will have complete cure of the anterior segment up to the level of the iris. And the systemic antibiotics, you don't need an intravitreal. The systemic antibiotics will actually penetrate into the sub-silicone oil space, the space between the silicone oil and the retina. And the level of antibiotics there is more than double. We did this study and it's published in IOVS. The level of antibiotics is double of what you would find in a non-vitrectomized eye. So it is adequate to take care of any infection in that space. When you remove the silicone oil and you saw these plugs, these are actually, what happens is you find very small membranes, and this is localized pus which gets it gets stuck over there. And if you use, even if you just use a flute needle, most of the time they will come out. Sometimes you'll see there's a membrane and you can, with a diamond dusted scratcher, you can just manipulate it a little bit and it will expose and come out. It will not cause any problem. In fact, if you had put silicone oil back into the eye, this entire sequence would have got shortened from 3 surgeries to 1 silicone oil removal. Because the entire reason for the recurrence is you hadn't yet reached a stable state. You removed the silicone oil, you put in gas, it did not give you adequate tamponade. And incidentally, with gas, you are less sure of what antibiotics to put. If it's a completely gas-filled eye, giving the full dose of antibiotics is actually going to be toxic because there's no fluid over there to mix with. If it's a silicone oil-filled eye, you know there's a retrosilicone space where around 1/4 of the fluid is there. Something like 1 ml of fluid is there. We've actually removed it and seen how much fluid do you normally find, and it varies from 0.6 ml to 1 ml. And you could give an intravitreal of say 1/3 the dose, and that would be enough. But you don't need that. What I'm trying to point out is you don't even need the intravitreal antibiotics. Combination of systemic and topical antibiotics would have taken care of this infection. So this is the important thing. The mess up occurred because of the cataract, which could be either because the patient started lying completely supine and had some lens touch, so it was a very rapid development of the cataract, or it was a lens touch, or a little bit of a little more than a touch, because otherwise you wouldn't get an intumescent cataract.
Okay, thank you very much, sir. So you have answered both the questions. One is the tamponade probably is silicone oil only. And number two, if it is silicone oil tamponade, we are using maybe 1/3 the dose, half to 1/3 the dosage of.
But otherwise you don't need it. You can just manage with systemic and topical antibiotics.
Yeah. Any other comments from any other panelists?
I think.
Hemant sir?
Yeah, that's fine, Appa. I think
Giridhar sir?
No, it's fine.
Okay. Okay.
Yeah.
Okay. So I will move to a small presentation on diabetic macular edema and challenges and how we are. Can you see the screen? Can you see the screen? Yeah, problems in DME management, good tight metabolic control, laser, anti-VEGF steroids, vitreous surgery for tractional DME and recalcitrant DME. This is our basic management of diabetic macular edema. Laser photocoagulation was the standard once upon a time. It helps to slow fluid leakage and reduce the amount of fluid. And the aim of treatment is to stabilize or further, prevent further vision loss. And then came all these studies like RESTORE, in which you can see that there is a significant improvement in vision, which is first shown with all the anti-VEGF agents, RISE and the RIDE, which showed that primarily anti-VEGF has a significant property to improve vision. And this was a landmark trial, the Protocol I, which showed that, triamcinolone, as with, prompt as well as deferred laser with ranibizumab gave great results, but triamcinolone reduced over a period of time. And this was the pseudophakic eyes and the number of cataract surgeries that is required. And then you had the aflibercept coming in, and aflibercept versus ranibizumab versus Avastin. This was the Protocol T, which showed that ranibizumab as well as aflibercept had equal results in long term. And then we had the dexamethasone also showing significant improvement in primary endpoint, also in vitrectomized eyes. And these are some of the costs that we use to calculate the treatment costs in India. And this would be the first year treatment results in terms of each strategy, what we would be using, number of injections and number of letters gain and the amount of money that is there. So this is one primary determinant in India, even now, regarding our patients' compliance. Then this was a study done by the VRSI, a DME snapshot, which shows that by years 2, 3, 4, about 30% of patients only start coming into our follow-ups, and that was a proportion of patients having accent breaks versus Avastin, etc. So a lot of patients lose to follow-up over the first, second, third years, and then this diabetic patient will have significant comorbidity burden from amputation, renal disease, stroke, heart attack, etc. A lot of such problems do happen, and average visit by typical DME patients in 6 months to a retina specialist, diabetologist, the nephrologist, the cardiologist is so mind-boggling that they slowly lose steam. And especially in the current pandemic, this is Shobha Shivaprasad in a recent study she found out that, patients with DME reported being uptight and they couldn't sleep. And the most important thing was that, they wanted to reduce the number of injections. So I wanted to ask some questions to the panel, very brief answers. We do not want to take a lot of time. So one is, in DME management, which drug do you initiate in a 55-year-old versus 65-year-old versus 75-year-old or a pseudophakic? We can start with Dr. Hemant and then Dr. Giridhar and Dr. Dinesh Talwar.
Sorry, yeah, I'm sorry. Yeah. In DME, what would you do? See,
initiation of treatment.
I initiate, on most of my patients, I would use an anti-VEGF drug. Yeah. But in certain cases of pseudophakics and those which have risk factors for systemic risk factors, I use steroid.
Okay.
And in this COVID time, I would sometimes go towards steroid because of the longer duration of action.
Okay, sir. What about Dr. Giridhar, sir? We have some more questions coming up, so we can qualify the cases later on.
Number one is, I don't think age is not a criteria for selection of a drug, number one. Okay. And in pseudophakic eyes, probably if there is significant edema, I may prefer to go in for steroid as the primary modality of treatment. But otherwise, age is not a criteria to decide which drug to use.
All right, sir.
Anti-VEGF is the first line. Anti-VEGF as the first line. And within the anti-VEGFs, if the patient says he can afford it and the vision is less than 6/24 or so, I may give him the choice of initial 2-3 injections with aflibercept.
Okay, because it showed a significant visual improvement in poor vision patients. Right. So over the next question, after 3 injections, edema reduced from 740 to 700 microns only. So there is not so much reduction of edema. And vision is like almost static. What would we do? Change the anti-VEGF, persist with the same drug for more than 3 more months, so that, total of 6 injections to the same anti-VEGF before you change it, change to steroids, or move ahead with vitrectomy, ILM peeling, etc. This is non-tractional.
Steroid.
I would change to steroid.
I, as far as I'm concerned, initially itself, I might have given steroid, because with a 740 micron thickness, it might be, I might have given steroid initially itself, but definitely if there is no response after 2 or 3 injections, shift to steroid.
Okay. In principle, if there are 2 injections with no change in OCT, then I would give.
Okay. So you wouldn't even wait for the 3rd injection?
Yes, but.
I think so. I to a certain extent agree with Dinesh on that. Even I am not very much this thing of continuing with the same drug, even after 2 injections, there's hardly any response. I mean, 20 micron, 15 micron.
Okay.
See, because 5% is no response. So that's what.
So what is a typical response that you want to see, sir?
10%.
10% per injection?
Per injection.
Okay. That's great. So let's move on, sir.
Want some improvement in vision. Even if there's an improvement in vision, I will accept it.
Yes.
See, I think at this moment, I'll just add one sentence.
Yes, sir.
Actually, this is based on a beautiful talk I heard recently in one of these DME, this thing. That is 30% of patients in all these trials, RISE, RIDE, were non-responders. And in the patients who, after the initial 3 injections, were poor response and who continued with the same drug, 50% of them continued to be non-responders. So this is a very important message. So there's no use sticking to the same drug for a long period of time.
Okay. So generally after 1 or 2 injections, no change in edema or improvement in vision, try to change. Yeah. And when we are changing, most of us will move to Ozurdex, then another anti-VEGF. What is your?
Ozurdex.
Okay, fine. Okay.
No change to an anti-VEGF.
Okay. After 3 injections, edema significantly reduced, but the patient developed a minor stroke. So what would we do? Stop treatment and ask him to come back after 3 months, or persist to the same drug PRN, or change the anti-VEGF for a PRN, change to steroids PRN, or move ahead with vitrectomy ILM peeling?
I would first, you see, DME is not the emergency that ARMD is. So I would actually wait for 2 months, maybe not 3 months, but at least 2 months. And after the patient stabilize clinically, either give him 0.3 milligrams of eccentrics if there's a issue of glaucoma, or give him a steroid for the initial injection.
Okay. How long after a thromboembolic event would you start him again on an anti-VEGF, sir?
Minimum 3 months.
Okay. Any change for anybody else?
I think I concur with
yeah,
Dinesh.
I think so, because I fully agree with what Dinesh said. DME is not an emergency.
Yeah.
Yes.
Yeah.
So DME is not an emergency, basically because even if you don't treat for some point of time and you then start treating, there is a catch-up increase in vision. Okay, after 6 months and 6 anti-VEGF injections, edema is reduced, but it persisting a little bit, and cataract is progressed and needs cataract surgery. So we'll perform cataract surgery and continue with the anti-VEGF injection as is normal, or Ozurdex and cataract surgery, change anti-VEGF and then cataract surgery. We'll do cataract surgery only after edema is completely absent.
No, you know, Ozurdex could become a preferred thing here because it can last for 3 months. So if I give Ozurdex, I would wait 1 month. You know, frankly speaking, I've had situations where the edema went off completely and the patient did not need the cataract, which was considered very significant, did not pose a problem later on. So sometimes that can also happen. But if I give Ozurdex, I will wait for a month. And if the patient says just continue me on, if there is a risk of glaucoma and all, I would just give an anti-VEGF and do the cataract surgery 10 days later. That gives the peak effect of the anti-VEGF and allows me to give another anti-VEGF 3 weeks later if required.
That's true. Yeah.
So do you actually wait for the edema to completely subside before you do the cataract surgery?
No.
In a cataract which is like NS2 with a little PSC, etc.
Depends on how much cataract.
Yeah, so NS2 with a little bit of PSC, not so much.
So like Dinesh said, you might find that the vision improves and there's nothing wrong with the vision, because vision would improve once the edema reduces. So how much is the significance of cataract? What is the contribution of the cataract to the vision is something that one needs to decide.
Correct. So how much is the edema causing decrease of vision? How much is the cataract causing decrease of vision? That has to be very clearly moved before we...
So if you believe cataract is significant cause of vision loss, and you don't want the edema to increase following the cataract surgery, so then you go ahead and give the injection. Glaucoma patients or ocular hypertension patients, I'd prefer to give anti-VEGF, and the others you can give Ozurdex.
Yeah. The red flag sign here is that if you operate a cataract surgery with macular edema on, it may have significant worsening, and that is why we are very categoric about it and want the edema to maximally reduce before we do cataract surgery. Patient is poor compliance and is not taking treatment as needed, and so edema is not reducing. So should we treat him as he comes for treatment, make him understand and continue anti-VEGF, move on Ozurdex or long-acting steroids, or move into surgery?
No, I think you need to talk to the patient. This is a situation where even giving Ozurdex is quite risky, because he may put the Ozurdex and never come back.
Yeah, and may have steroid-induced complications as well.
I agree with Girdhar. If the patient is not compliant with anti-VEGF, you give him Ozurdex, he goes and gets glaucoma, and then comes back with loss of vision.
Yeah. So it's a very important thing that compliance is needed, and we need to talk to them and find out why there is no compliance. Some of the people may have systemic issues. Some of them may be amputees, may are not coming like that. Okay. So do you use OCT biomarkers to guide your treatment plans? Like inflammatory biomarkers, what are they in your mind? And is that equal to steroids? Or there are no change in treatment plans? Whatever be the OCT, this is what we are going to do.
I would start with anti-VEGF and shift to steroids based on the response or lack of response.
So an initial OCT biomarker does not give you any...
All of them respond to both. They respond to anti-VEGF agents and they respond to steroids. And safety-wise, I believe anti-VEGF agent scores.
The only thing that I would look at is in OCT and the duration of edema, the chronicity, very significant edema, I would probably go towards the steroid, but otherwise anti-VEGF, like Dinesh has said, is probably.
Yeah, I mean, basically, I think when patients come with significant diabetic macular edema, 700, 800, I think it's very important to see whether they have any systemic cause for that. Recent infection, uncontrolled diabetes, hypertension, all these things are one of the causes for, such a significant macular edema. Therefore, that's very important. Therefore, it's not only necessary for us to treat the edema, but also just, do a complete systemic evaluation to see whether there are any other coexisting factors which are responsible for such a sudden increase in the macular edema.
This is the last question. In bilateral central large DME, what is your treatment plan? Is it simultaneous bilateral injection, call back after a week for sequential secondary injection, anti-VEGF in one eye or Sudex in the other eye? What do you think?
I don't believe in bilateral injections at the same time. Believe me, you need one case of endophthalmitis to remove this desire of yours to give bilateral injections.
Yeah.
And I have seen
some countries like Singapore regularly give that.
Somebody else's case is enough, actually. You don't have to see your own case for that.
Yeah.
No, I think in our country, I personally feel I would look at patient safety. I don't give bilateral simultaneous.
Okay. None of us do. None of us give. But would you do a sequential second injection after 1 week, which means that the number of visits that the patient has to do will be...
I would rather do it 1 week later.
Yes.
I would do it 1 week or 2 weeks.
Yeah.
I currently follow this.
As far as DME is concerned, if the bilateral DME, sometimes I do it only at the end of 1 month. Because DME is not an emergency. 1 month delay. See, what I do is that I do not know. This is my concept that if I'm going to give the same drug in both the eye, I would like to see whether it's really working in one eye. Because if it's not working in one eye, there's every chance it's not going to work in the other eye. So I would give one shot in one eye, call the patient after a month, do the OCT and see what's happening. And if that's working there, then probably at this moment of time, I may start both the eyes together with a short gap.
I think the real message that is coming is DME is not an emergency. Don't treat it like ARMD.
Wet ARMD is different.
Yeah, even in this COVID times, actually, we have had many patients who missed injections and bled in AMD. That's a problem with AMD.
Many patients with diabetic macular edema who have missed follow-up, I think, are better off when they came back because there's a natural course which is quite favorable because they are all sitting at home. The diabetes is well controlled. They're not going to the office. So basically, they're all coming back with better macular thickness without any treatment.
Giridhar, here the advantage is no tension, home food, no junk food, timely food, and some exercises because they need to do something, some activities. So I think that's what is helping them.
Thank you very much. I think I would move to the next case from Chitrakoot. Dr. Priyamvrat, please, you can. Priyamvrat? Yeah.
Yes, sir.
Yeah.
Good evening, everyone. So this is a case of a 50-year-old diabetic woman who was a diabetic since past 8 years. She came to us with a complaint of progressive diminution of vision in the left eye since 2 weeks. And she also had a history of burning micturition with fever since 1 month. On examination, the right eye was unremarkable, whereas in the left eye, visual acuity was hand movements and there were 1+ cells and 1+ flare in the anterior chamber. There was grade 3 vitritis and we could hardly see the fundus. The disc was barely seen. So with this picture, we had a provisional diagnosis of endogenous endophthalmitis in our mind and went for the labs, which were more or less normal, except for the blood sugars. The fasting was 148 and postprandial sugars were 306. We also sent the samples for a blood culture and urine culture. The next day, we subjected her for a diagnostic pars plana vitrectomy with intravitreal antibiotics, that is vancomycin and ceftazidime, along with dexamethasone injection. We sent the vitreous sample for gram stain and KH mount, along with culture sensitivity, and also for viral PCR. So 3 days later, the media improved and we could appreciate these yellowish, fluffy lesions, multifocal over the posterior pole indicated by these yellow arrows. The visual acuity at this stage was 5/60. On peripheral examination, there were typical tongue-shaped yellow lesions in the nasal periphery, and inferiorly, there were patches of yellowish lesions indicated by the yellow arrows. OCT was performed through the lesion near the superior temporal arcade, and we can see that the lesion is emerging into the vitreoretinal interface with the inner retinal involvement. The lesions in the inferior periphery, they showed a necrotizing retinitis with full thickness neural tissue defect. The subfoveal photoreceptors also showed some damage, and there was stippled loss over the subfoveal photoreceptors. We performed a fluorescein angiography, which more or less showed a huge amount of disc leak and vascular leakages. And with the typical appearance of tongue-shaped lesions and retinitis on OCT, we considered viral retinitis and started her on oral antivirals, that is valcyclovir. So on the very next day, the next morning, we had the blood culture reports with us, and it showed Staph hominis, which was sensitive to vancomycin and clindamycin. And on clinical examination, what was seen was worsening. The vitritis had increased and the retinitis patches had spread. Also, the visual acuity had dropped to 3/60. So having the blood culture reports positive and worsening was present, we planned to inject another shot of clindamycin along with dexamethasone. So next day, the worsening further increased, though the vitritis had reduced, but the retinitis had spread all around the disc, and there was a peripapillary retinitis. Visual acuity had fallen to counting finger close to face. A fluorescein angiogram was performed, and the extent of the lesions were delineated by the hyperfluorescent lesions around the disc, and they had a more or less of a geographical pattern. So with this picture now again, we had stopped the oral clindamycin, which we had started initially, but continued with the oral valcyclovir 1 gram 3 times a day. On follow-up at 2 weeks, we can see that the response to antivirals was pretty good. There was pigmentary stippling all around the disc in the geographical pattern, and the visual acuity was 6/18. We performed a fundus autofluorescence, which showed a stippled hyperautofluorescence all around the disc, and the borders were somewhat hypoautofluorescent. So the patient is still on follow-up, doing well, and there's no evidence of any retinal detachment, and the visual acuity has improved to 6/12. Now over to my mentor, Dr. Alok sir, for continuing with the discussion.
Yeah, good evening all. Am I audible, sir? Gopal sir? Hello?
Alok, yeah, you are audible. Please
yeah,
continue.
Okay. Thank you for this opportunity to present our work from Chitrakoot. So this was an interesting case which we initially thought of to be endogenous endophthalmitis because of her poor diabetic control presentation. But once we did the diagnostic vitrectomy, we saw those peripheral tongue-shaped retinitis patches. We thought it was ARN, and we started the patient on valcyclovir, oral valcyclovir. The interesting thing was there was worsening of retinitis, and so I'll just Priyavrat, can you switch the switch to next slide, please?
Yeah. Yes, sir.
So for endogenous endophthalmitis, as I said, the favoring points were history of diabetes, burning, micturition, and fever. A positive blood culture, I put a question mark there. I'll have a one slide discussion on that. And the picture which was against was that the peripheral tongue-shaped retinitis, which was very typical of ARN, which supported our ARN diagnosis. But again, against ARN, multifocal posterior lesions, which are not very commonly seen with acute retinal necrosis, that was something which we thought was not going in favor of ARN. Next slide, please. Priyavrat. Yeah. So the blood culture which we did was positive for staph, and then we went through the literature, and it is seen that it is one of the most common contaminant seen in blood culture. So that was one thing which actually fooled us, and we made a diagnosis, change our diagnosis from ARN to endogenous endophthalmitis once the blood culture was there and there was worsening of retinitis. Next, please. We had few questions. Why did the inflammation worsen after starting the patient on valcyclovir if we were dealing with the ARN? And why did the retinitis worsen, although there was decrease in vitritis after intravitreal injection? why did the retinitis worsen? And probably it was related to progression of retinitis with intravitreal steroid, which did reduce the inflammation, but the retinitis progressed. Now, steroids have been used as an adjunct therapy in patients with ARN and to control the vitreous inflammation or inflammatory damage. So we really don't know how, because we just gave intravitreal dexamethasone, we didn't put the patient on oral steroids. Why did the retinitis progress? The patient was still on valcyclovir. So that's something which we could not understand. Next slide, please. So the third point, which was that posterior multifocal retinitis. So we went through the literature and we found these two very important articles, and which say that these lesions which look more like PORN, and there is one report also in PORN which is usually seen in immunocompromised patient. There is a report where it was seen in even immunocompetent patient, and these two reports just say that it could be a spectrum of necrotizing herpetic retinopathy. At one end is simple ARN, and to the other end is PORN, and the spectrum depends on the immune state of the host. The more immune deficient the host is, the spectrum shifts towards spawn. So we feel that it could be a posterior herpetic retinitis, which we mistaken it as endogenous endophthalmitis because of a contaminant growth of staph. And once we shifted the patient on continuous treatment of valcyclovir, and in fact we had also injected intravitreal ganciclovir, and we got good results after that. The case is now open for discussion. And I would like to acknowledge Professor Amod Gupta here, who has always been supporting us on all our uveitic cases.
Thank you, Alok. Thank you very much. You can stop sharing.
Yes.
Yeah.
Alok, I just wanted to ask you, did you did a vitreous biopsy and you sent a sample for both PCR and culture?
Yes, sir.
Came out of it, I suppose.
Sir, actually, we don't have an in-house PCR facility. So we had sent, and because of this COVID issue, the sample got lost somewhere in between. So we didn't get the PCR report. The culture report, the vitreous culture report for bacteria and all was negative.
So if that had not happened, I think you would have been in a better shape.
Yes.
So how often is it that there is usually when there is a viral retinitis, I would usually think that the anterior segment is also significantly inflamed, not like 1+ cells and flare. What is your thought process?
No, not every time do you see that. No? There would be a lot of times we are able to see ARN fairly well in the fundus. The view is fairly good even for an indirect ophthalmoscopy. But it is not that it will preclude your view of the fundus entirely. A lot of times you are able to see the fundus.
Yes.
Yeah.
Yes, sir. Yeah, I think that was also one reason that we initially thought of endogenous endophthalmitis, and that was the reason why we did a diagnostic vitrectomy. And once we did vitrectomy, we realized that it was an ARN.
No, the thing is, what was the need to give intravitreal steroid, basically?
So it was just to, along with the antibiotics, we gave intravitreal steroid.
Yeah, I think this is one of the things I'd like to point out. Maybe one message could be, in cases, even if you think it's exogenous endophthalmitis, endogenous endophthalmitis, any form of bacterial endophthalmitis, even if you don't give the steroid, you'll get as good a response. You don't need the steroids to get a better response.
Fasten the response.
On the negative side, you could end up with a fungal endophthalmitis and you worsen it. Here you got a viral endophthalmitis and you worsened it. So basically, we would be probably better off just leaving steroids alone, intravitreal steroids alone, as a method of management. So,
yeah. Oh, Rohan, you want to say something?
Sir, A very interesting case, Dr. Alok, and I think in such cases, at day one, when you are not seeing anything, this is how it has to go probably. But I would just comment that when you see your later on OCTs and you find that the choroid is absolutely clear. So metastatic endop would probably originate from the choroid. So it is not a metastatic endop, it is a retinitis. And then you would have to think what are the DDs of a retinitis with tan uveitis. So I would go with Behçet's disease, sarcoidosis, and viral retinitis as you have gone. And like I put in the chat box, we have also published one viral retinitis in immunocomponent, which goes on to the posterior pole. So don't call it an ARN because ARN has a very specific definition. Right. But it is a viral retinitis going on to the posterior pole and probably benefiting from your valsivir and maybe initially worsening with the steroids.
Actually, there is no entity called posterior, PON. Actually, even that starts basically, it involves the inner retina, and also it's not that, it just involves the outer retina. So basically what he says is absolutely correct. Even we had one patient, which I recently presented also, of a patient with in an immunocompetent state, bilateral disease, very aggressive disease. So I fully agree. There are a lot of variations in presentation. And I think, as Dinesh said, when we give intravitreal steroid, even in case of infective endophthalmitis, we should be very clear about the etiology when we give it. Probably when we give it with the second injection, if you're very sure that it's a bacterial endophthalmitis where you have tackled the infection and there's only inflammation, I agree with you because there are a lot of reports. But then when you're not sure of the diagnosis and if it's a fungal endophthalmitis and you end up giving an intravitreal steroid, it's likely to worsen the condition. So when we give intravitreal steroids for infective etiologies, I think it has to be very, very carefully done. And even in uveitis, I think it's very, you have to make sure that there is no infective element before we inject intravitreal steroids.
Yes. Rima has one point to make, the last comment, and then we'll move to the next case.
Yeah, Gopal, just one comment, Dr. Alok. I think the administration of intravitreal steroid here created an atmosphere of local immunosuppression, which worsened retinitis. So we are very careful when we are thinking of an infectious etiology. We really don't give intravitreal steroids, and in viral, I think not really. So my question was, as I wrote earlier, did you rule out syphilitic retinitis?
Yeah, the TPHA and VDRL both were negative in our case.
So I think it's because of the intravitreal steroid that precipitated the retinitis.
Yeah, actually we didn't think, because the second time when the patient worsened with vitritis, increasing vitritis, and the blood culture came positive, we thought it could be a endogenous endophthalmitis, and that's why we gave Clinda with dexamethasone. And that caused the worsening of retinitis.
Okay.
So in these cases, would you also consider systemic steroids instead of intravitreal steroids?
In these means endogenous endophthalmitis?
Endogenous endophthalmitis or viral retinitis?
Oh, no. Viral retinitis, the regime that is recommended and what we follow is induction phase is IV acyclovir, starting oral steroids 2 days after starting IV. For then 2 weeks we continue, and then we come to the maintenance phase with oral acyclovir or val acyclovir, continuing the steroids and then stopping the steroids 2 days before the antivirals, never intravitreal steroids. And if it is endogenous endophthalmitis, the treatment is vitrectomy. We have to debulk the vitreous and we give IV antibiotics, we don't give steroids.
Any other opinions? We'll go if there are any other opinions.
I think fine.
No, we will go to the next case.
Thank you.
Samir, thank you very much, Alok. And Samir and Dr. Manoj from Chaitanya Eye Hospital, Trivandrum, will speak on Vitiliform curios. Samir, please.
Yep. So is it clear?
Yeah.
Good evening. I'm Dr. Samir from Chaitanya Hospital. Today, I would like to briefly discuss about 2 interesting cases, which we would like to call as Vitiliform curios. The first case is regarding a 67-year-old female with hypertension, dyslipidemia, and ischemic heart disease, presented to us with the right eye diminution of vision. Visual acuity was correctable to 6.9/N6 in right eye and 6.6/N6 in left eye. Anterior segment was normal,
And both a fundus examination showed this vitelliform-like deposits. Vitelliform-like deposits in the macular region of both the eyes. Spectral domain OCT was showing hyperreflective homogeneous lesions in the subretinal space in the right eye, and also you can note a shallow PD in the subfoveal region of right eye. In the left eye OCT, these hyperreflective lesions were present in the outer retinal layers, and also you can note that there was a small focal double layer sign in the parafoveal region of left eye. Autofluorescence was done, and it was actually resembling more like a pattern dystrophy with increased reference from the autofluorescence from the vitelliform deposits. Infrared images also showing the same, like increased reference from it, and angiography was done, and there was no presence of any CNVM. This is a series of OCT of right eye from 2017 to 2019. As you can see that initially the small PED in the subfoveal region slightly increased in size, and later it got flattened up, following which the central migration of the vitelliform deposits happened, and slowly you can see it got reabsorbed almost fully. And also note that in all the sections, there were prominent dilatation of the vessels in the choroidal layer. The first four pictures in the top are actually of right eye. You can see that the vitelliform deposits over a period of time slowly got reabsorbed fully. But in left eye, you can see that even though it initially decreased, but again it started reappearing mostly in the temporal part of the fovea. Is again the left eye OCT follow-up. The pictures are arranged in a clockwise manner. We were actually more concerned about this hyperreflective spot area. You can see that this hyperreflective region increased in fastness to surrounding. Later, a small amount of SRF also started developing there, but it resolved by own later. Similarly, another lesion also started just above the fovea, superior to fovea, with a prominent amount of SRF that also got resolved later by its own. We tried to co-localize that hyperreflective spot with OCT angiography, and we could find a abnormal neovascular network corresponding to that hyperreflective spot in the avascular layer. And also we noted that the vessels in the choroidal layer were very prominent in the choroidal slabs beneath the spots. This is of left eye on follow-up. On the late 2019, this hyperreflective spot started appearing near the in the parafoveal region also, and there was a lot of SRF also started developing it, and vision also started deteriorated. At this point, we decided to treat the patient. We tried to co-localize again with this area in OCT angiography, but we couldn't find any abnormal network there. And also, but even though we couldn't find any network, but we also noted that in the choroidal slab there were prominent vessels here also. This is, however, like when we repeated the oscillography, this is the early octa pictures, and this is the recent ones. When we compared it, we noted that the size of the network has actually slightly increased, and also we noted that in the choroidal slab, that the prominent vessels also start appearing, new ones were appearing there. So we treated the patient with 2 doses of anti-HF injections, and post-treatment, we note that the SRF has already, like, almost fully reabsorbed and vision restored back to 6/6. The second case is regarding a relatively young patient, 45-year-old lady having hypertension, dysthyroidism, and migraine, presented to us with diminution of vision in the right eye. Left eye vision was normal, but right eye vision was improving only to 6/18 and 24. On fundus examination, there were RP changes in both the eyes with a vitelliform-like deposit in the macular region of only in the right eye. Note that there was no anterior chamber cells or anterior vitreous cells in this case. Autofluorescence was showing an hypo area at the center with rings of hyperfluorescence around it. What was interesting in this case was that OCT was showing a dome-shaped elevation in the subfoveal region, which was actually compressing the whole of the choroid. As if you look clearly, look carefully, you can see that actually that lesion looks like it's appearing to originating from the sclera itself. Also note that there is the amount of SRF and widely found deposit above the lesion. Angiography was done and there was no evidence of CNVM. And fluorescein angiography was actually showing a perifoveal capillary leak and also a trivial vasculitis at the peripheral part, more in favor of an inflammatory pathology. Also noted in ICG, there was a central hypo area corresponding to the choroidal lesion, which was persisting in the late phases also, indicating a full thickness choroidal involvement. Left eye OCT was showing a small PED detachment in the subfoveal, in the parafoveal region, maybe subfoveal, with a hyperreflective spot above it. And here also note that the pachychoroid nature of the choroid here. Corresponding to the OSP PED, there was a minimal leak also in the angiogram. B scan was done, but the lesion was too small to be picked up in ultrasound, so we couldn't get in B scan. Systemic workup was done, and most of the infectious and inflammatory workup all were negative actually. Like with the MRI orbit was also normal. CT thorax was done, that was also normal. And pulmonologist actually ruled out both the possibility of TB and sarcoidosis, and there was no family history positive also in this case. Patient was lost to follow, but she again presented after 6 months. This is the OCT during that time. We could see that the lesion was almost remaining the same. The SRF, Vitreous deposit, and even the vision was remaining the same. So OPTA was also done, and there was no evidence of any abnormal vascular network, and there was a persistent central choroidal void present there. So these are the points I would like to discuss about these two cases. This shallow PD, which was present in the first case in adult, we thought that this is adult onset for macular dystrophy. Is it a sign of CNV? Can we still call this as adult onset macular dystrophy? The non-exudative CNVM which is associated with it, is this just an association, or is there any choroidal component which is contributing to this disease? Regarding the case 2, do this widely found deposits happen secondary to a inflammatory pathology? So I would over to Manoj sir for further discussion, sir.
Shamir, can you? Yeah.
Yeah.
Manoj, can you continue? Are you continuing?
Yes, I'll continue.
Yeah.
Shamir, can you just unshare?
Yeah, sir. 1 second, sir. Actually, my system is little stuck. 1 second, sir. Okay. Sir, I just unshared. Can you see me?
Yeah. Okay. Gopal, can you see my slides now?
No.
I think you stopped sharing, Manoj.
Yeah, 1 second.
Can we discuss basically in this way? I think most of the points are already there.
Can you see the slides now?
No. Yeah.
Yeah, now we can. Yes.
Yeah. Thank you. So basically, here we were trying to see the first time when we saw the PEDs. Initially, our diagnosis was adult onset foveal widely formed dystrophy because of the characteristic autofluorescence pattern. That time, the doubt that we had is are PEDs very common in these entities? So this is as this picture is already shown. You see the PEDs decreased with follow-up. And following the PED resolution, there was migration of the widely formed deposits towards the center. Now, this is well reported, so there is nothing unusual about it. PEDs are reported in patients with AVD. In the absence of choroidal neovascularization, it is in the range of around 40%. But the more pertinent question is, now in a patient, in a disease with adult widely formed dystrophy, the pathology is primarily at the level of the photoreceptors. So now, why should you have a PED? Why should you have a retinal pigment epithelial disease? Is it fluid or is it something else? Now, I could not find any answer for this. But then when I looked at the histopathological studies have shown that there is dense eosinophilic material and past positive material below the RPE and also in the subretinal space. So probably this is not fluid, but some other material which looks like fluid on the OCT. Again, studies have shown that PED happens during evolution. You don't see it in the vitally formed stage. You see it in the vitally disruptive stage or in the later stages. And this is probably an attempt to clear all the vitally formed deposits from the retina. Now, the second part of the question, non-exudative CNM, is it an association of pathology? When I looked at the literature, Koskas had mentioned that all these eyes with vitally formed dystrophies have choroidal thinning. Faraday et al. Had reported that the choroidal thickness may be variable. It may be highest in the vitally formed stage, and it may be least in the atrophic stage. But at least in our situation, in our case, even at the late stage of the disease, we had a thick pachychoroid. So the question is, did the thicker dysfunctional choroid predispose to the CNVM in this eye? And also considering the fact that pachychoroid may be more common in our population. But the imaging gave us a lot of clues. Now, if you look at the autofluorescence, later when we looked at the autofluorescence, we realized that the area of RPE damage is much more extensive. And this is not what you see in vitally formed dystrophies. And also the underlying, the non-exudative CNVM seems to be underlying that region. You had an underlying pachy vessel corresponding to that. Even in the eye, which had typical pattern dystrophy-like appearance, there was pachy vessels underneath. Also, the fact that there was disappearance and reappearance of the vitally formed lesions, as was seen in the left eye. Now, this is not observed in the natural course of vitally formed dystrophy. So, because of these reasons, we thought that it could be the pachychoroid phenotype in these patients that was responsible for these manifestations. Again, when we looked at multimodal imaging, we realized that not all the SRF pockets could be localized to the CNVM. All this could be localized to the new vitally formed lesions that were appearing, or at least, and just before there happened to be a small change in the character of these vitally formed lesions. And they could also be localized to a dilated choroidal vessels on the octa slabs. So we believe that this could be an acquired vitally formed lesion in a pachychoroid mimicking a pattern dystrophy. Vitally formed deposits in pachychoroid is not really well studied in literature. I could not find any major articles, though there is some poster that is mentioned. PEDs in such entities now probably need more careful evaluation, unlike the PED that we normally see in vitally formed dystrophies. And non-exudative lesions may progress rapidly in these eyes. If you look at the natural history of non-exudative CNVMs, over 1 year, 1/4 of the eyes can progress to exudative CNVMs. Only 1/4. So, but in our situation, it seemed to progress faster, and therefore we need to keep this in mind. Regarding the second case, when we looked at the acquired vitally formed series by Bailey-Freund, we could not find any inflammatory pathology being implicated. So we even thought of acute exudative vitally formed maculopathy, but this is a bilateral and usually polymorphous lesion, so this was right away ruled out. We also thought that the granuloma scan does show some autofluorescence. We could isolate 2 papers. Here, the characteristic lesion that is described is a perigranuloma hyperautofluorescent. That's basically the RP being affected there. In our case, also there is that ring, but in the center there's definitely a more intense hyperautofluorescence which corresponded to the vitally formed deposits. Again, when we look at multimodal imaging, the clue came here. If you look at the late phase ICGs, you see this patchy hyperfluorescence there. This is what we normally see in CSRs. So this gave us a clue. Again, the presence of pachychoroid, the presence of an RP, small pigment epithelial detachment, and the pachy vessels in the left eye. All this gave us a clue that again this was again a pachychoroid phenotype. Probably the vitally formed lesions happened at that location because the granuloma kind of chronically compressed the choriac capillaries, and therefore vitally formed deposits happen there. And this probably represents a treatable form of adult vitally formed, acquired vitally formed lesion. Now, Spade, in fact, had put forth a hypothesis that when there is a chronic separation of photoreceptors from the retinal pigment epithelium, the debris cannot be phagocytized by the cannot be extruded by the retinal pigment epithelium, and therefore can end up with widely found deposits, and that's why you get widely found deposits in chronic CSR. Another curious thing is this patient was on topiramate for migraine. So when you looked in the literature, there is a single report of a patient who was on topiramate who developed widely formed deposition. But if you read the article, no, they have not. It's not very clearly mentioned whether it is a cause or it is just an association. So finally, I think this is the worry that I have, and I would like the panel to address this. I feel that there is a need for a nomenclature change. The term dystrophy itself, I think I'm not happy with it, because Gas, when he coined this term, it was based on hereditary findings. But if you look at the later reports, many of the adult widely formed dystrophies, they are isolated cases. And a lot of genetic analysis studies have also shown that in many instances, the genetic analysis is negative. So we have definitely a group of patients who do not fit into the term adult onset foveal widely formed dystrophy. So probably we need a better classification. Thank you.
Thank you, Manoj. You can stop sharing. So Manoj is proposing change in classification systems. Over to the panelists.
No, I think basically, I mean, as far as, now I think it's more of acquired vitelliform lesions. I think basically in a broad format, there are many conditions that come into acquired vitelliform lesions. The thing is, I agree that probably the nomenclature of AOFVD requires a rethink in the current situation. I mean, that's something. But what he has shown as far as the first case is concerned is a natural course of vitelliform lesions where they come, they can disappear. And the serous macular detachments have been reported in vitelliform lesions in the absence of any neovascular membrane. Now, the octa pictures that he showed, I think the panel can also comment on that. I was not very convinced about the presence of a neovascular network, a very definite neovascular network there. And if you see the final OCT prior to the intravitreal injection, I do not see any irregularity of the retinal pigment epithelium, because we are looking at a type 1 neovascular network. You need a space between the Bruch's membrane and the retinal pigment epithelium. I do not know whether I missed it, but I did not see any irregularity. It was just a serous macular detachment. And probably, I do not know how, whether it was treated immediately or whether there was a time period which was given where to look for any natural resolution. So presence of serous macular detachment in vitelliform lesions have been described. And typically that may not be that, whether it is a genuine neovascular network is difficult to say, but nonetheless, neovascular networks have been described in this form of disease. So as for the first case is concerned, as far as the second case is concerned, I think the other panelists can comment on that. Again, very interesting case. The second case is quite interesting. But in the second case, if you look at the OCT, and if you look at that hyperreflective area in the OCT and compare it to the color photo shows only a small speck of a so-called vitelliform lesion, but the OCT shows a much larger area. Therefore, whether it's a vitelliform lesion or whether it is some sort of a deposit that we normally see in some of these patients with a long-standing serous fluid in the macula is something which can be discussed.
Sir, regarding the second case, on the top of the granuloma was a very focal area of vitelliform deposit. The rest was SRF. The rest was just SRF.
That vitelliform deposit that you are saying, yes, the size of that which we are seeing in the OCT is far more than what we are seeing in the color photo. That's what I was saying. So whether there is, I'm not questioning the presence of vitelliform deposit, but what I'm saying is probably the vitelliform deposit, was it something pre-existing? And along with that, there is an additional element that has come in. You understand me? So yes, whether there is something like that. So that's what I was just wondering, because the size is quite big, huge. Quite a lot of, hyperreflective material there, but the vitelliform deposit is quite small. So whether it's, whether it's really the whole thing is a vitelliform deposit or whether there is something more in it is something which probably we do not know.
And regarding the first case, Shamir, can you just show the picture? There's definitely a small a focal area of DLS, very, very clear separation of the retinal pigment epithelium from the brooks.
Achha. Okay. No, but then CNVM can be there because CNVM is described in all these conditions. It's been described, and since you are having a long follow-up, you have been able to detect everything. So there's a lot of message as far as that case is concerned.
Sir, my point is it is not adult vitiliform dystrophy at all, sir. It was primarily a pachychoroid disease which actually manifested with these changes.
As far as the choroid is concerned, Manoj, I think
yes,
we are looking at the choroid more and more now. So basically, earlier we never used to look at the choroid. So nowadays, everything we are looking at the choroid, and therefore we are, probably we are understanding many things now. Pachychoroid itself has come that way only by looking at the choroid. So basically, that's an interesting point that you have got, that the presence of a thick choroid in these sort of clinical situations, and probably we need to see. I don't know. We cannot say. What I mean to say is that very interesting finding, and probably this is something that we are looking into now, and which we have not been looking into earlier. That is the thickness of the choroid in these sort of situations.
Yes.
Sir, may I intervene? For want of time, I think we should move on. It was an excellent discussion.
Can I make one short comment, Gopal?
Yeah, please, Anand.
Second case, if you see that one eye which had that so-called granuloma, I think that could be ascribed to what is also known as dome-shaped maculopathy.
It's very focal, no?
No. Yeah, so it is focal. If you see that autofluorescence, you can see a linear form. You see this is coming up from the sclera. And if you see the autofluorescence, you can see a very linear pattern. This has been generally described with myopes, but we have seen this happen, and it has been reported also in emetropes also. And you see this push on the RP in a patient who is predisposed to this kind of a vitelliform degeneration will develop this kind of serous detachment and this vitelliform dystrophy. These vitelliform deposits.
Anand, the ICG,
the FFA or the autofluorescence which you have there, you can see that linearly.
But isn't the choroid thickened on the either side, which will not be there in the dome-shaped maculopathy?
No, that can happen. That can happen. But you see this bottom right, it's a very beautiful picture here. The very beautiful picture here in the bottom right of this FFA ICG. You can see that linear pattern. If you perhaps do an OCT with a raster along that, if you can manage that, you might see that dome going right there.
Yeah, we have another opinion from Dr. Avi. He says that it looks like a congenital choroidal macro vessel. Can you just comment on that?
No, but we don't see that in the ICG.
Can I make a comment?
Yeah, please go ahead.
Yeah, please. The last comment, I think.
The point, Anand, against the dome-shaped lesion is the presence of hypo on the ICG. You see the ICG, there's a nice central hypo that is persisting from the early phase to the late phase, which you will get in a full thickness granuloma. And the inflammatory signs. You see on the angiogram, you see perifoveal leakages, you see peripheral leakages, all that goes in favor of some kind of an inflammatory lesion. In a dome-shaped, why would you get a hypo on an ICG?
That may be there, but what I'm saying is that little degeneration there, right at the fovea, that fluid, possibly is contributed also by the dome.
Okay.
Which we have seen.
Okay, let me intervene here. And let us move on. And thank you very much, Manoj and Dr. Samir. Now I have two Divyas. Divya Alex will be presenting when antibodies are driving a car.
Is my slide visible, sir?
Yeah, please make it full screen.
Yes. Is it okay now? So presenting a case of cancer-associated retinopathy. So it was a 70-year-old female came to us with sudden onset defective vision in both the eyes for the past 1 week, which was associated with flashes of light. She was a non-diabetic and hypertensive with a recent history of ischemic heart disease on medical management. She was a diagnosed case of carcinoma endometrium with para-aortic lymph node involvement, stage 3, and she was on chemotherapy for the same. So her best corrected visual acuity in both the eyes was 624. Anterior segment examination was quite within normal limit. Her color vision was quite poor with the Ishihara, and the fundus examination was normal. Even though she was advised for investigation, she couldn't do on the same day, but she came after 3 days with a sudden drop of vision, further vision in both the eyes, about counting finger close to face. And the anterior segment examination was within normal limits. And the fundus examination revealed nothing significant except for a few peripheral pigmentary changes. And the wide field optos also showed a normal fundus examination. And the fundus autofluorescence was also normal except for a few vitreous floaters. And we did the full field ERG, and it showed reduction in the scotopic as well as photopic responses in both the eyes, and it was and the visual evoked potential also showed a normal P2 latency but with decreased amplitude. And the HFA also showed grossly diminished field visuals in both the eyes. And MRI brain, which was done previously, it showed nothing features of any metastasis. It showed only features of chronic small vessel ischemic changes and age-related changes. And the SD-OCT, it showed disruption of the inner segment, outer segment of the photoreceptors that we call the ellipsoid zone in both the eyes in all the sessions. There was massive disruption of the ellipsoid zone. And in wide field OCT, you can see the extent of the ellipsoid disruption in both the eyes. And there was RNFL thinning, extensive in the right eye and mild in the left eye. And the ganglion cell layer thickness was also diminished in both the eyes. And with the considering the age of the patient and all the imaging findings, we came to a diagnosis of cancer-associated retinopathy, and she was started on IV methyl prednisolone, 250 mg in 4 divided doses, and she was sent for PET scan in the meanwhile, and anti-cancer antibodies which was sent for, and she found to have anti-recoverin antibody positive, and this was done in a US lab. And meanwhile, she underwent total abdominal hysterectomy. This was in a due course of 1 month time. So this was the presentation. After 5 days of intravenous methyl prednisolone, her vision improved from hand movements to 660, and after 2 weeks of oral steroid, 660 to 618, and further improvement to 612 after slow tapering doses of steroids in a 4 weeks time. And as you can see in the follow-up, as her visual acuity has improved, the retinal nerve fiber has also improved in thickness, and the ganglion cell layer has also improved in thickness. And her color vision has regained to normal within 1 month of time. And most importantly, you can see the ellipsoid layer, that is the ISOS junction, it has regenerated at the fovea in both the eyes. So passing on to my mentor Divya ma'am for discussing the case.
Hi, Deep. Okay. So this was a case wherein already the patient is quite elderly, and was a case of already diagnosed CA endometrium. So when such patient, like unlike the cases which was presented earlier, wherein there was a lot of confusion because whether it could be paraneoplastic, non-paraneoplastic AAR. In this case, because the patient was already a diagnosed case of CA endometrium. And the progression in the vision, deterioration of the vision was like very rapid. And the fundus initially in most of these cases may be shows very subtle changes, which was very evident in this case also. If you look carefully, you could see that in the autofluorescence, there was some subtle hypo around the perifoveal area. In the center, you could see that in the perifoveal area, you can see little hypo, but those are very subtle changes. But the changes could be picked up 3 days later when the patient presented with further deterioration of vision. So this rapid progression is one thing which makes you think in terms of something like a carcinoma-related retinopathy when already his patient is a diagnosed case of CA. And the OCT findings, which, Divya, can you show that OCT findings? So the OCT findings also is a very characteristic which shows the outer retinal layer loss. And the ERG also was very specific in that it showed extensive flattening of both the scotopic and photopic waves. And to confirm, actually, we did the anti-retinal antibody, only anti-recoverin was done. Fortunately, the patient could get the test done from US. So in this particular case, the diagnosis was more or less kind of more straight, but in case if this patient was a middle-aged with not a known history of carcinoma, then it would be a diagnostic dilemma wherein most of these, can you go to the differentials slide, Divya? So other the other differentials would come in play, wherein like a non-paraneoplastic entities also like discussed earlier. So those would be like Azure, which is an acute zonal occult outer retinopathy, or cases with retinitis pigmentosa, especially those X-linked carrier, or a non-paraneoplastic area. So these few considerations, because in this case, the patient was quite elderly. The Azure usually present in 40s, and you see that the CME and may not be seen in cases of Azure, but in some cases of retinitis pigmentosa and PNAR, you can see that CME may be there. The bony spicule characteristically you see more in RP, but the pigmentary dispersion changes are less seen in cases of Azure or AR. And ERG is also like in RP, you might see in the early, the scotopic response may be reduced and it may be extinguished in the late stages. But CAR, like unlike others, the ERG changes may be very prominent even in the early stages. The anti-retinal antibodies, unfortunately, may not help you to come to a conclusion in these cases, because even in some cases of RP and any immune-related or an inflammatory conditions can give positive reports of anti-retinal antibodies. But with the other findings, considering the clinical features and the other investigations, might help to come to a conclusion. So anti-retinal bodies per se may not help you to clinch any diagnosis. So my query to the panel in this situation is that now we have the many a times, even in the reports, you see that the patients may not get a good visual recovery after treating with even immunosuppressant steroids. This patient fortunately showed a response, maybe because the patient was treated with the IV pulse methylprednisolone therapy. So the question is that how long should you treat these patients with the steroids, or at what point of time would you consider treating with other modalities like plasmapheresis or other immunomodulatory therapy? Any experience from the panel? And another question I had was, suppose if this patient was a mid patient with this picture and no history of family history of RP, then how would you go about? Like, would you consider doing an extensive workup, or would you consider like genetic testing first? And as mentioned, that getting an anti-retinal antibodies from India is little difficult. And maybe because this one single antibody would cost around 20,000 rupees for the patient. So these are my points.
Thank you, Divya. You can stop sharing the screen. In a patient who is already diagnosed to be having CA endometrium, it makes pretty sense. But otherwise, I think in the presence of an RP, even if there is no family history, I think what is the opinion of the panel? Dinesh, Dr. Dinesh, Dr. Hemant? Yeah.
No, I think here it was pretty straightforward. But I think whenever you see a an atypical presentation like this, and the OCT features were very classical in this, so I don't think it was fairly going in the same lines. So if the history was not there of a kind of a CA endometrium, I would have probably investigated them thoroughly. And like you rightly said, because this patient recently deteriorated in vision, you gave IVMP, the vision improvement has also been very good.
Okay.
I think we've lost him for a moment. I think the message that I seem to be getting here is that if you have a sudden loss of vision, even if you don't have, you're not looking at an optic nerve or pathology,
I think both of you are speaking, I think.
Okay, let him speak. I can't hear. Yeah, but I thought he stopped.
No, but his connectivity has some issue. Hemanthamurthy sir, can you stop your video and speak? You have some connectivity issues. You can stop your video and then you can speak.
Back in. Hemant, can you speak now?
No, we are not hearing.
Muted.
You are muted.
Yeah, you speak, Dinesh. I think you can continue. Yeah.
No, I was only saying that in a situation where you have sudden vision loss, even if the signs are not looking very clear-cut, and you don't have this kind of clear-cut history, does it seem worthwhile to always give IV methylprednisolone? Because that's the only thing. Because most of the things where you're talking about, you're not getting a clear-cut. See, these are typical situations where you say, okay, the history is there of a carcinoma and things like that. What if the history was not there? Then what do you do?
Yeah, definitely we would look for other causes of investigate for uveitis only. But considering this 70-year-old,
the problem is that the time that you're going to investigate, you would lose the patient. You would lose the eyes. So my question is, and that's the real point, from a practical point of view, should I consider giving methylprednisolone even to 70-year-olds if there's a sudden vision loss? Or do I have an alternative to this? Or is it that there are other very clear pointers when I should give it?
That is actually opening the Pandora's box. I think that's a very, very generalized question. And I don't think that any 70-year-old, we can just give IV methylprednisolone when there is a decrease of vision. We need to investigate him. We need investigations for at least ruling out malignancy, ruling out inflammatory disease.
See, within a week, you got improvement. You got an improvement of a level you're not expecting to get in any other treatment. And you lost the vision within a period of 2 weeks.
Yeah. You should not take 2 weeks to investigate, sir. I think over a week, I think we should get an imaging done, etc., etc. And if everything comes on negative and we are completely unexplainable with the sudden vision loss, then yes, with an explained risk, I think we can move in, but not without doing all those investigations. What do you say, Divya?
Yeah, even I am also a little hesitant to start immediately with IVMP with this picture. But I don't know from other.
That's the whole question, because
Dinesh, with the clinical picture that they had, let alone, let's say the history was not there, it's worthwhile investigating this patient, because that would help you in your diagnosis, because the OCT, the FA and the
yeah, the point is well taken, sir. Yeah.
Fairly such investigation.
Okay.
Okay, sir. Thank you for the. Yeah.
Can I ask one question, sir?
Yes, Divya.
To the panel. Actually, for overall, the clinical cause of CAR is one of deterioration, even if you treat the patient with steroids or not. But in this case, we had a happy ending. So I am just doubting whether the surgical removal of the tumor would have prevented worsening of the disease, because theoretically it removes the generation of further autoantibodies. So any comments on that, sir?
I think
How long after the methylprednisolone was the tumor removed?
It was in a course of 1 month, sir, everything this, or after 5 days of IVMP, definitely the patient vision improved, but on the due course of oral steroid, patient underwent hysterectomy also. That could have been one reason, because in small cell cancer, carcinoma and all, usually.
No. Do you have a long-term follow-up?
Yes, sir. Yes, sir. It's almost 1 year now.
Maybe.
Okay.
Yeah.
Okay. So let us think that the removal of the tumor reduced the antibodies.
Just one comment, like even if the tumor removal is done alone, actually the reports have shown that it may not cause a further improvement much. So maybe the tumor removal along with the treatment have helped in, I mean, the patient was lucky to have got the improvement. Still, we don't know how long to treat this patient and whether
So even now the patient is on steroids.
No.
Immunosuppression.
Immunosuppression, long-term immunosuppression. Okay. Okay. Thank you, Divya. Now we will move on to Dr. Pooja and Dr. Rehana, who will be presenting a case of mistaken identity. Again, another case which will baffle us, all these similar looking cases. Yeah.
Good evening, everyone. I would like to thank Gopal sir for giving me an opportunity to present here. This is a case of a mistaken identity. Today, I'll be taking you through the journey of a 32-year-old female who was being investigated for interstitial lung disease.
Pooja, I think that black box is coming onto the right side of the screen.
Yes.
Can you do something about it?
Yes, sir. Sorry. She was being investigated for interstitial lung disease on systemic immunosuppression, mycophenolate mofetil, and systemic steroids. She's also a case of suspected Sjogren syndrome. On ophthalmic evaluation, her vision in both eye was 6.6, near vision N6. Intraocular pressure measurement, both eye NCT was 12 mmHg. Anterior segment findings in both eye were within normal limits. Fundus evaluation of the right eye, media was clear, disc normal, well circumscribed sensorineural detachment of size 5 disc diameters, present superotemporal to the disc. Few RPE changes, but mottling changes were noticed infranasal to the disc, about 2 disc diameters away from the disc. Left eye also showed a sensorineural detachment of size 4 disc diameters, superotemporal to the disc, 2 disc diameters away from the disc. RPE mottling changes are also noted in the left eye, superior to the disc. At this point of time, when did an OCT through the lesion showed subretinal fluid in both the eyes, right eye more than left eye. The fluid was not extending to the fovea, both eye foveal contour was maintained. At this point of time, our diagnosis was steroid-induced CSCR. We have planned to decrease the systemic steroids and observe. When the patient reviewed after 2 weeks, there was drop in vision in both eye, right eye more than left eye. Fluid started developing at the fovea. AF showed RP changes, more extensive, sparing the fovea. ICG showed both hypo and hyperfluorescent areas. As seen in this clinical picture, they developed hard exudates temporal to the disc along with ILM folds at the macula. OCT showed subretinal as well as intraretinal fluid in the right eye, subretinal fluid in the left eye. Fundus Fluorescein Angiography showed multiple hyperfluorescent areas along with extensive window defects. In the late phases showed pinpoint leakages along with disc leak in the right eye. Left eye also showed pinpoint leakages along with disc leak. ICG and indocyanine green angiography showed hypofluorescent areas along with hyperfluorescence. B-scan ultrasound showed choroidal thickening. Considering these factors of multiple pinpoint leakages, choroidal thickening, retinal detachments, our diagnosis was inclined towards Harada component of VKH or probable VKH. So we increased the tablet MMF to 1 gram TID along with IV methylprednisolone 1 gram for 3 days, followed by Vicelone on tapering basis. 2 weeks later, when we reviewed the patient, the vision in the left eye improved, which gave us hope. However, the right eye vision was still 6/36. The amount of hard exudates that were present increased in number along with ILM folds in both the eyes. OCT showed increase in the fluid, subretinal fluid in both the eyes. However, right eye was more than left eye. Autofluorescent images showed hypo to hyper autofluorescence in both the eyes, right eye more than left eye, encroaching onto the fovea. 1 week after review, vision was in the right eye was 2/60, left eye 6/9 NIP. Discs started developing edema, disc margins were blurred, hard exudates increased in number, ILM folds were present, RP mottling changes were noted. Autofluorescent was suggestive of both hypo to hyper autofluorescent areas encroaching onto the fovea. Left eye also showed increase in the number of hard exudates, ILM folds, and RP changes. Autofluorescent was suggestive of hypo to hyper autofluorescent areas. OCT showed increase in the amount of subretinal fluid in the right eye as well as increase in the fluid in the left eye. At this point of time, the patient was also complaining of severe backache. The rheumatologist had reviewed the patient and advised MRI spine, which was suggestive of aggressive myeloproliferative disorder bar neoplasm, leukemia bar lymphoma, other small cell neoplasm. Ultrasound abdomen was suggestive of ovarian origin mass or broad ligament lesion. Bone marrow biopsy at this point was suggestive of metastasis with probable primary in the breast. Breast ultrasound guided core biopsy was done, which gave us the diagnosis of bilateral breast invasive lobular neoplasm with metastasis, and it was falling under the diagnosis of BIRETS grade 6. Considering the systemic diagnosis, along with extensive RP changes, choroidal thickening, extensive retinal detachment, we retrospectively diagnosed to be BIDUMP, bilateral diffuse uveal melanocytic proliferation. The patient was started on chemotherapy with the docetaxel for bilateral carcinoma breast with bone marrow metastasis. Over to Dr. Rehna ma'am for further discussion.
Then you could share your screen, please. Are you muted? Rehna, you are muted.
Am I audible now, sir?
Yeah.
Thanks, Pooja, and good evening, everyone. So we have just gone through a case which have actually taken us through a long-winded route, misleading us to different diagnoses before coming to the final one. So we have here a patient with sensitive neural detachment, a young female, healthy female on steroids, which prompted us to think about steroid-induced CSR. What made us think about what Koyanagi Harada was that when the patient presented again with multiple sensory neural detachments, decreased vision, and the fundus fluorescein angiography when it was done showing this pinpoint leaks as well as the disc leakage and diffuse choroidal thickening on the B scan. The points against which was there were a lot of RP changes even from initial presentation, which is not very common with VKH because RP changes appear towards the later stages when the patient is not adequately treated. And also we also thought about is kind of any posterior segment inflammation in the eye, especially with the background of this interstitial lung disease, and the patient was on steroids. Other differential diagnoses which were there in our mind, one was idiopathic uveal effusion syndrome, but at the points against it was that the patient didn't have any choroidal detachment. It was mainly involving the posterior pole and there was no scleral thickening. Posterior scleritis was another one, but the patient didn't have any pain and there were no choroidal folds and there were no fluid in the subtenon space. Metastasis and primary choroidal lymphoma were the other differential diagnoses. Hypertensive choroidopathy can be completely ruled out as the picture was entirely different and the patient's blood pressure was normal. So we came to a diagnosis of BIDUMP in this case with this extensive exudative retinal detachment, extensive RP changes on fundus fluorescein, on fundus autofluorescence, diffuse choroidal thickening in this patient when she was having breast carcinoma with extensive metastasis. So what is BIDUMP or melanocytic bilateral diffuse uveal melanocytic proliferation? It's a rare paraneoplastic syndrome that can lead to profound vision loss and benign proliferation of choroidal melanocytes. The proliferative melanocytes are histopathologically unrelated to the non-ocular systemic tumors and is often associated with occult but advanced carcinoma and an indicator of poor prognosis. Mean age of presentation is 68 years, ranging from 34 to 89. There is no gender predilection, first reported by McMur in 1970, and since then around 50 cases are reported in the literature. The patients present with bilateral vision loss usually precede the systemic malignancy by 3 to 12 months, and the pathogenesis is tumor-induced ectopic peptides, unlike other paraneoplastic syndrome where there is a spectrum of autoimmune disorder which is suspected. Most common causative malignancies, ovarian carcinoma in women and pancreatic or lung cancer in men. So there is only one case which is reported in literature where BIDEM is associated with metastatic breast cancer. Gas has mentioned 5 clinical characters for BIDEM: development of multiple, slightly elevated, pigmented or non-pigmented uveal melanocytic tumors, evidence of diffuse thickening of the uveal tract, multiple round or oval subtle red patches at the level of RPE in the posterior fundus, striking pattern on FA of multifocal areas of early hyperfluorescence corresponding with these patches, exudative retinal detachments, and rapidly progressing cataracts. So as treatment, these patients should undergo extensive workup for systemic non-ocular malignancy and appropriate treatment of that malignancy. Plasma exchange has been shown to improve visual acuity, resolve subretinal fluid, and decrease choroidal thickening. Mean survival is reported at 12 to 15.7 months from the time of ocular diagnosis. So this is a clinical picture of our patient post-chemotherapy, that is after 6 cycles, 3 months after the treatment. The vision in the right eye improved to 6.9 and left eye improved to 6.12. The disc edema has improved in the right eye but was still persisting. The subretinal fluid at the posterior pole has almost completely resolved except a bit in the inferior quadrant. There were extensive retinal pigment damage as seen from the autofluorescence. So the point I would like to highlight from this case is that when patients with presence with exudative detachment with any of these atypical signs, especially this extensive RPE changes, paraneoplastic syndrome should be borne in mind, and they should be investigated with blood test, radiological examinations, and PET scan to rule out any or to find out underlying malignancy. So these are our questions to the expert panel. So we found that the disc edema developed from the almost the third or fourth visit. How can we explain the disc edema in this patient? And literature also says rapidly developing cataract is a characteristic feature of BIDEM, but our patient didn't have any cataract at any stage. And how is it in your experience? Thank you.
Stop sharing. Over to the panel. Yeah.
I think it's. I mean, I have not seen any patients with disc edema or basically BIDEM is any of these paraneoplastic syndromes. We have seen some of them, but not specifically in this characteristic feature. Not sure whether you would always see this rapidly progressing cataract, although they have given that as one of the diagnostic features of this. Difficult. I mean, personally, I wouldn't be able to contribute more. Other panelists can add on if they have seen any more cases of BIDEM.
No, for me, the learning process is that an autofluorescence must be done in all these cases to check for this kind of extensive change, because this was not, from the clinical picture, this was not evident. So most of this thing is coming out from the autofluorescence, then you start suspecting something else is going on. So this is what is the important thing here. But when you have a patient, when you have patients who you have this kind of effect on vision or changes which you're not able to explain, just a localized detachment, get an autofluorescence done. Then it may show you much more than what you're seeing otherwise.
Could you evaluate the choroid on the OCT?
The choroids appeared a bit lumpy, elevated on the OCT.
There is a question in the chat box as to whether there were hyperreflective dots in the choroid.
On ICG?
No, in the choroid, in the OCT, hyperreflective dots in the choroid. There's a question in the chat box.
Yeah.
Your OCT did not show the choroid very clearly, I suppose.
Yeah. It's a spectral OCT, sir.
Oh, that's
so that is a problem.
PDI,
Yeah. No, these are all very rare conditions. So basically, I mean, I think you like to ask some ocular.
Yeah. Dr. Avi, you can come in, please. You please explain your point.
Yeah, in my department, we saw a few cases of CAR or MAR, where you see all the cancer associated with retinopathy. You can see all the metastatic cells infiltrating the choriocapillaries, the choroid. So if you do an OCT, EDI, or even just a simple OCT that can image the choriocapillaries, you can see this small hyperreflective dot that can direct you or give you a sign for the diagnosis and not mistaking it to VKH, for example.
Yeah, okay. But hyperreflective dots in the choroid have been described in so many other conditions, even actually in patients with wet AMD and all. They are nowadays describing patients with hyperreflective dots. So from the OCT point of view, I think, what are the possible biomarkers? Are there any biomarkers to tell us except the undulations? Now, undulations in the choroid can be seen in inflammatory disease. Now, what is very, unfortunately, in this particular patient, if you look at the undulations, they don't look like any metastatic undulation. They look more like the undulation that we see in inflammatory diseases. So, the reason why, in this particular case, the team has been able to think of such a diagnosis is because of the history, the systemic history, isn't it?
Yes.
So, yeah, the systemic.
Till that point of time when she presented with the backache and we got her imaged and there was a support, she's a 30-year-old with an inflammatory disease or seeing rheumatology. We were completely foxed.
Yeah, that's what. So basically, I think that's where the whole thing is. So it's like, multiple myeloma being diagnosed in a patient coming with any inflammation in the eye, and even elderly patients coming with uveitis and finally be landing up with some sort of a cancer. So these are, probably, I think very rare clinical situations, because I agree with Dinesh that, autofluorescence is quite useful. But then even with autofluorescence, I think we will not think of such a, diagnosis unless and until there is a systemic, direction, where there is something else happening in the...
The age was a significant negative, sir. If it were to be a 65, 70-year-old person who had come to us with similar findings, we would have thought about malignancy also.
Yeah.
But
I think their point was very clear. I think what you have made out about the pigmentary changes that were seen in the early part went against your VKH, and then you...
Correct.
Yes, that was correct, sir.
The clincher here, I suppose.
Correct. There are some negatives, like the disc edema is not described in...
it's not described. So that's...
in BIDM. And
and you don't have rapidly progressive cataracts, which I think you've not...
But generally, the age of presentation of a BIDM is slightly older, maybe 60 plus. And that is why probably cataract is also much rapidly progressing in that age group.
Can I make a comment, Gopal?
Yeah, please, Rohan.
Yeah. Gopal, if you see your right eye OCT, the lumpy bumpy appearance as you're talking about, I think we should not ignore that. And since your patient also has multiple metastases, it could probably just be a micrometastasis with a disc infiltration rather than a B-dump.
Okay.
So, but the pigmentary changes definitely point towards B-dump. But then I would still, and it responded so well to chemotherapy. So whether it is a micrometastasis or it is actually B-dump, I think no one can actually tell.
Okay. Thank you, Rohan. With that, I think we can move to the last case. If there are no other comments, Dr. Blessy from Little Flower and Dr. Ramya would be presenting on a curious...
चक्कर से नहीं होता ये घी चक्कर होता है ऐसे ही बढ़ गया होगा रेगुलर चेकअप कराओ थोड़े दिन
Shop, can you mute him?
नमक नहीं खाना है नमक नहीं खाना
Okay,
yeah, I muted him.
Thank you, sir. So is my screen visible?
Yeah.
Okay. Good evening, everyone. I would like to thank Cochin Ophthalmic Club and Ramya ma'am for this wonderful opportunity. So I'm presenting a case of 26 years old young man. He is a salesman. He presented with sudden onset bilateral defective vision for 2 days with central scotoma. So he had history of fever with malaise 1 week before, no history of rashes, no history of loss of weight or night sweats, no history of GIT disturbances or hematuria. So we examined him. His best corrected vision in right eye was 20/200 with N10 near vision, and in left eye was 20/80 with N8 near vision. And fundus picture shows both eyes normal disc, and retinal sheen at macula and both eyes was altered, and there was a intraretinal hemorrhage at the supratemporal aspect of the macula in right eye. And coming to the magnified image of the macula, there was an orange-yellow lesion can be appreciated at the fovea in both eyes with surrounding ILM folds, better in the left eye. Also, there were a few areas of yellowish subretinal deposits in the posterior pole of both eyes, represented by black arrows in this picture. We further evaluated the patient, and his autofluorescence show hyper autofluorescence corresponding to the orange lesion in the fovea. And OCT was taken, and both eyes show altered foveal contour. And there was a hyperreflective lesion extending from the ellipsoid zone up to the outer nuclear layer with the disruption of the external limiting membrane in both eyes. And we also did the fluorescein angiography, which came out to be normal. There was no hyperfluorescent lesion. So based on these clinical features and investigations, we made a provisional diagnosis of bilateral maculopathy with right eye hemorrhagic retinopathy. Can be acute macular neuroretinopathy, possibly post-viral. So due to our current circumstances, we sent the patient to a fever clinic, and his total count was slightly reduced, and his platelet count was 80,000, and his dengue IgM was positive. So we made a final diagnosis of bilateral dengue-associated foveolitis, and we started him on oral steroids at a dose of 1 mg per kg for 2 weeks. And finally, after 2 weeks, he came for follow-up. This was a pre and post-treatment OCT pictures. And there was a drastic improvement in vision from right eye 20/200 to 20/20, and left eye 20/80 to 20/20 with N6 near vision in both eyes. And his post-treatment fundus pictures shows normal. And we gradually tapered steroids in this patient. Thank you, and over to Ramya ma'am.
Okay, Blessy, can you please stop sharing? Sir, am I audible?
Yes, Ramya, you are. Please go ahead.
Okay. Yeah. So my case is an uncommon presentation of a very common infectious disease, and it seemed very relevant in this current scenario. And I thank Dr. Gopal for giving this opportunity in this wonderful program. The incidence of dengue-associated maculopathy in dengue fever ranges from around 7 to 40%, and the posterior segment is most commonly affected. And it leads to vision-threatening complication in around 5 to 8% of the cases. So 3 patterns of dengue-associated maculopathy or DAM has been recognized so far. So one is the diffuse retinal thickening. The other is cystoid macular edema, usually associated with occlusive vasculitis or optic neuritis, and foveolitis. So foveolitis, basically, it is common in young males, usually presents bilaterally 6 to 7 days after the onset of the acute febrile illness. This delay possibly could be due to the delay in the production of antibodies and immune complex deposition, and most commonly these are associated with a low platelet count. So it has a characteristic fundus picture of a yellowish orange foveal lesion, and this condition is termed as foveolitis based on the unique feature which are captured on the OCT, like the hyperreflective lesion extending from the ellipsoid zone into the outer nuclear layer, disruption of the external limiting membrane and iosois junction, and the absent foveal tint. FFA, although not diagnostic, but may present with perivascular leakage, especially when associated with immune-mediated vasculitis. With the advent of newer investigation modalities like OCT angiography and Swepso's OCT, Newer diagnosis like acute macular neuroretinopathy has also been seen associated with dengue fever. And it has been shown with OCTA that not only the deep capillary plexus, but also the superficial capillary plexus can also get affected in a case of dengue fever. A new nomenclature that has been added to the DAM spectra with the help of the SPEPSOS technology is the dengue-induced inflammatory ischemic fovealitis and automaculopathy, in short form DIII-FOM, which is a newer addition in this category, which includes features like vitreous cells, hyperreflective OPL and ONN, retinal thickening, and hyperreflective conical foveal elevation, in addition to the fovealitis, what we have seen earlier. So whatever be the presentation, luckily these features respond very well to oral steroids with good resolution and near normal restoration of the retinal layers on OCT. So my questions to the panel is that, are steroids mandatory in the treatment of fovealitis, or does it have a spontaneous recovery? Does it cause any visual deterioration if the steroids are not given? The first question. Are there other reasons that we should be looking for once we see cases of fovealitis, like in this current scenario, especially in this scenario, and OCTA in DAM, does it have any significance in the diagnosis or prognostication? Over to the panel, please.
Thank you, Ramya. You can stop sharing. I think Hemant sir, there has been a lot of dengue hemorrhagic fever from Karnataka.
Fortunately, unfortunately, what we always see is, these post-viral focal or fovealitis that you see, they do respond even without treatment. Sometimes they do respond without treatment, and that has been described also. But I think steroids just hasten the improvement as what you have experienced in your patient, because I think in 2 weeks the whole thing just resolved normally. They do resolve spontaneously.
But my question is, sir, if steroids not given, does it leave any vision problem?
Difficult to say, ma. We see the number of cases are not there for us to do something like controlled trial to say what would be the best option.
But generally, fovea is involved, sir. It would be prudent
we give steroid. I agree. So see, the point is,
if we are reasonably clear about the diagnosis also.
Yeah, it's known that it does respond without the steroid also. But I think most of us, because vision is affected, we would have given. We have done OCTA in other conditions, but because it's just at the fovea, I don't know how much OCTA would reveal in this condition. We were seen in macular neuropathy that you do see these changes that occur in the superficial and deep plexus. But in fovealitis, I'm not sure whether you would be able to appreciate so much, because it's such a small area of involvement.
I think I would go by one thing only in this situation. When you have a sight-threatening thing, or what looks sight-threatening, you're not sure whether this is self-limiting or not. Though the history, though the general course, it suggests that it is self-limiting. My question to myself would be, can it harm? Correct. If it can't harm, I would give it.
Correct.
I think the general consensus is that it doesn't harm. It doesn't harm the retinopathy changes. Like, it's not like ARN where you give steroids and you find that you suddenly lost the eye. So here it doesn't harm. So chances are, so from that point of view, I would say better to give a short course, see if it's improving, and continue on the same.
Now, I know we do give steroids when there is immune complex or vasculitis, occlusive vasculitis, we give steroids because that is known to improve. In this particularly, I would agree with it. Once fovea is involved, we would always treat, because it's, I would always err on this side than trying a chance to find out whether it's going to affect the vision ultimately.
Giridhar sir, for final comments.
Nothing more.
Yeah, Anand, you wanted to speak? Yeah.
Yeah, I just see, once you know that it's dengue and it's not like ARN or something like that, then it's not just about giving the steroids, it's also about giving the steroids fast enough, early in the course. Because what we've seen, and I mean, I'm quoting a series from Dr. Ratnam's experience, is that if you give it fast, you reduce the damage to the foveal architecture. And in fact, it actually improves better in the long term if you give that short course of steroids earlier. That I think is an important thing.
So my question, in this current scenario, is there any other viruses or anything else that you would like to investigate once you see a patient with foveolitis, especially in this scenario?
In this scenario means COVID.
COVID situation, yes, sir. Because we have to.
But because COVID has a very different picture, it would always produce some sort of an occlusion of vascular occlusions have been reported, and you see them. But I'm not sure about foveolitis, because this is an immune response that you see as foveolitis. I'm not sure how much it would produce.
So pertaining to your question about COVID, the COVID test itself is not is very suspect. So unless you're going to do RT-PCR with the antibody test, it's difficult to say anything.
Yeah, it is difficult to say. That's true. But it's known to produce vascular occlusions.
Yes, we have seen significant percentage of occlusions.
Occlusions. It produces vascular occlusions, arterial predominantly. So I think that's one picture that you.
Now, if dengue turns out to be negative, what other viruses would you suspect? Is there anything else that you should be suspecting?
But I would just treat it as like what you did. It responds, so I wouldn't worry too much about it because it's such a local involvement.
Okay, Dr. Nasik Hassan is asking, is there any empirical role of doxycycline before they start on steroids?
I don't know.
I was about to ask this question from a non-retinal perspective. What systemic medications would your physician or someone advise before you start this patient on high dose steroids? Or what did your internist or physician say? You must have obviously taken opinion from them before you start steroids.
See, basically, most of these patients are coming to us. I mean, already they are under treatment, or they have had treatment, or they are in the process of completing their treatment. So basically, I don't think that, that question has got much of a relevance. It's not that we diagnose foveolitis and then the patient goes to a doctor and then, he gets the diagnosis of dengue done. It's not, it's always the other way around as far as most of these posts, I mean, whether it is leptospirosis, dengue, etc. What, Hemant, do you agree with me on that?
Yeah.
Yeah, it's not that we are not the primary, doctors who are treating it. So most of these patients have had an attack of fever. They have been admitted somewhere. Many of them, in fact, have been admitted and treated somewhere. They've already been treated, and subsequently they realize that the eye is creating some problems. They come to the ophthalmologist, and they are diagnosed, and they are started on steroids. So basically, it's not that, it's not the other way around.
My one comment that I would, you gave them 1 milligram per kg body weight.
1 milligram per kilogram body weight. Yes.
That you're given an immunosuppression dose. I would give an anti-inflammatory dose, which could be much less, because you are given an actually immunosuppressive dose, which is generally not necessary for these conditions.
Okay.
Normally, they say for an adult to have a therapeutic effect of oral steroids, you need to give about 45 to 50 milligram per day.
That should be good.
But then the pathology says that it is an immune-mediated pathology, so you should be tackling at the immune system rather. So,
but an anti-inflammatory dose seems to work very well in these. It's not necessary to give total immunosuppression because it's such a local disease. So it does work,
Okay, sir.
It's not a generalized disease like VKH, wherein you need to give 1 milligram per kg body weight.
Yeah, very true. And a short course is enough.
Dr. Dinesh?
I think
Dinesh is tired.
Okay, Dr. Giridhar is tired. Okay, I get the cue.
Yeah, I would say.
So over to, thank you very much. I think I should hand over to Dr. Sai for closing the session.
So I'm here. I just began proceedings and I'm here to conclude also. And I think this is one of the webinars which has been really exciting, and more importantly, we finished on time. Exactly 6 to 9 was our time, and so I thank Dr. Giridhar, Dr. Dinesh Talwar, Dr. Hemant Murthy for being moderators in this session and leading a wonderful discussion, and all the other presenters from all over the country, and a special thanks to the presenters from the University of Tel Aviv who have presented their cases and given comments in this meeting. I also thank Allergan for supporting this meeting and hope to see you all soon in another edition of a CME series from Cochin Ophthalmic Club. So thanks a lot.
I just wanted to add, Dr. Sai, that we have about 1,000 clicks in the YouTube.
That's fantastic. Yeah. You made a comment initially that it's not going to cross 1,000, but you have been proved wrong yet again. That's so our Cochin Ophthalmic Club YouTube channel has, I think, become very popular now. So thanks a lot, everyone. Take care. Good night.
Thank you.
Thank you, Hemant and Dinesh.
Excellent discussion. Thank you all.
Thank you. Thank you very much.
Yeah.
Got a good collection
Thank you, Gopal and Cochin Ophthalmic. Thank you.
Thank you, Rad. Thank you, Anand. Yeah.
Thank you.
Bye.
Sorry, I didn't have the video.
It's okay, sir. It's okay. It looks a little odd in the YouTube. That's
yeah.
Let me stop. No, let me just stop the 1 second.
You can stop the sharing.
Sir.
YouTube sharing, you can stop. Then if you want, you can chat for a few minutes.
No, I will set it right tomorrow.